Assalamu alaikum. Can anybody tell me if the voice is clear or not on the chat? Nice. Because I shall not see chats except when I will open it, I will ask your pardon. I cannot see whatever you will say unless we will finish a lecture, and then I will open the window of the chat. I am Dr. Hatem Saneer Baha, Anesthesia Registrar, Abha Maternity and Children Hospital. I have the pleasure to be your host today regarding procedural sedation course or conscious sedation course. Our course today consists of 5 lectures. We will start with procedural sedation and monitoring, pharmacology of sedatives and its antidotes, airway management, emergencies during sedation, and lastly will be a summary of the whole 4 lectures. It is the sedation practice guidelines. After each lecture, I will give you around 5 minutes to speak, to say whatever question you want. If anything, if any note you need, take on a paper now, so that when we will open discussion, you can elaborate whatever you want. And by the end of the day, we can ask any question regarding any lecture we discussed since now. After finishing the course, you will receive from the company 2 issues. The first one is a PDF book. It was issued by Sebahi. And you will receive assessment, course assessment, exam. The exam is not intended to be as a test for you. It is more than this. It is a test for me, for our company, how we delivered the message to you. Did we succeed to deliver successful message to you or not? If somebody will ask when we will take rest, we will have one big rest. It will be around 12, 10, something like this for prayer. If we can take 5 to 10 minute rest after the second lecture, well and good. If we cannot, we will proceed, inshallah, so that by 2 p.m. we will try to finish our course. So now let's start. Why it is important to govern sedation practice? Why Sebahi has put 1/3 of their standards regarding sedation practice? If you know that any drug which depresses the central nervous system is having a potential to impair respiration, circulation, or both of them, especially when you are speaking about old age or extreme of age, neonate, something like this. And if you know that complication rate during sedation is too much higher than during general anesthesia, how much high? I will tell you. If we are speaking about general anesthesia for normal healthy person, there will be complication in one patient in every 250,000 patients. It means 4 patients per million. But if we are speaking about the same person, the same normal person who is undergoing sedation, maybe a complication will occur in 1 patient in every 3,500 patients. It means that the risk of sedation for the same person is 80 times higher during sedation than during general anesthesia. Type. I will ask you now a question and wait for feedback from the chat. Tell me, why do you think like this? Give me only whatever you are thinking. Why sedation is 80 times more risky than general anesthesia? Give me your thoughts. Interact with me, please. Let's proceed. This slide is a very important slide, and we will see maybe 3 times today. This is level of sedation. It is starting. This terminology you will see a lot. You will see there is something called minimal sedation, moderate sedation, deep sedation, and general anesthesia. There is another name for minimal sedation. It is anxiolysis. For moderate sedation, you can see conscious sedation, and sometimes you are hearing procedural sedation. Because we said that any medication that is affecting the central nervous system can affect the patient respiration and circulation, and of course the brain, we tried to find the findings in each system by which, if I will see this effect, I can say that this level of sedation is reached. Yalla, let's take it one by one. For minimal sedation, the responsiveness of the patient will be normal response to verbal stimulation. What is the normal response for verbal stimulation? If I will ask you a question, you can ask me. You can answer me. And if you want something from me, you will ask me. It means you can initiate the speech, you can initiate the questioning, and you can answer freely. This is accepted in minimal sedation. His airway will be unaffected at all. The spontaneous ventilation is unaffected at all. And the cardiovascular function also is unaffected. And take care of the terminology that I used is unaffected. It is normal response. So any one of us now can be in a minimal sedation state. But why we are not telling that everybody is minimal sedation? Because not all of us are taking medication. If you are taking medication and this medication puts you on this level of sedation, well and good, you are minimally sedated. But if you are not taking any medication, I cannot say that you are sedated. The second level of sedation is moderate sedation, in which the patient response is he is responding to verbal or tactile stimulation. It means what? What is the difference between this item and the previous one in minimal sedation? The response is interaction due to my stimulation. He cannot initiate the speech. If you will leave him, he will be calm and stand still. But once you will speak with him or her, or you will touch, at that time he will open his eyes, he will start communicating with you. So the communication here is secondary thing, started after my stimulation. What about the airway? There is no intervention required, and there is a difference between no intervention required and unaffected. No intervention required means there is affection, but this affection doesn't need interaction from the practitioner. Again, in the spontaneous ventilation, it is adequate. It is little or minimally affected, but it is still adequate. It doesn't need intervention. The cardiovascular function is usually maintained. If we will increase the depth of sedation more and more, what will happen? The patient will respond only after following repeated or painful stimulation. Maybe normal touch will not affect him, will not open his eyes. If you will speak with him, no response. Loud voice, maybe yes, maybe no. But repeated or painful stimulation, it will give response. The affection of the airway and ventilation will be more. Intervention may be required for airway patency. Spontaneous ventilation may be inadequate. But still, the last thing to be affected is the cardiovascular function. Still, the cardiovascular function is usually maintained. When we will reach the final level, the general anesthesia level, The patient will be unarousable even for painful stimulation. Intervention is oftenly required for airway patency, and spontaneous ventilation is frequently inadequate, and maybe the cardiovascular function will be impaired. If you will see, this definition is mentioned by the Joint Commission. What is meant by conscious sedation or moderate sedation? It is a drug-induced depression of consciousness during which the patient is purposefully responding to verbal commands. Either commands are alone or accompanied by light tactile stimulation, by light touch. But take care, reflex withdrawal from painful stimulus is not considered as a purposeful response. There is no intervention required to maintain a patent airway, and spontaneous ventilation is adequate. Cardiovascular function is usually maintained. This is translation or making a paragraph from the previous slide. In order to understand and to realize which affection is there now in the spontaneous ventilation and in the responsiveness of the patient, I have to monitor the patient well. What should I monitor? I will monitor the conscious level and responsiveness, his respiratory rate and pattern, oxygenation, ventilation, ECG and heart rate, and lastly, blood pressure. So those 6 areas of monitoring, I will monitor my patient thoroughly in each area. But the question is how? We have 2 ways of monitoring, or 2 major categories of monitors: human monitors and machinery monitors. Human monitors like what? Like my eyes, my ears, my finger, my tongue. I can use my vision, my hearing, my touch, and verbal communication in order to monitor and see where is my patient now, in which level of sedation. But of course, I cannot depend on the human monitor alone. I need a machine. Machine like what? ECG machine, pulse oximeter, blood pressure, capnography, bispectral index, and we will go through one by one of such things. Let's see the conscious level and responsiveness. Patient responding to command or light tactile stimulation, and he will be frequently assessed using a sedation scale, and we will see the sedation scale in the next slide. Documentation of level of consciousness should be done at least every 15 minutes. And take care, when we are telling at least, it tells that maybe we can use it more frequently. Maybe the patient condition necessitates that we will use it every 5 minutes, every 10 minutes, but not more than 15 minutes. We will consider using a PIS machine, and we will see it now. Type. What scale we can use? A lot of scales are available in the market. One of them is called modified Ramsey scale. In modified Ramsey scale, Ramsey has put this scale for ICU patients, and he put it as 6 steps. He gave every step a score. Score 1, 2, 3, 4, 5, 6. And then the definition of the scoring is mentioned here in the indication. If the patient is anxious, agitated, or restless, this is modified Ramsey scale 1. If the patient is awake, cooperative, oriented, tranquil, and accepts mechanical ventilation, this is 2. If the patient is semi-asleep but responding to commands, this is 3. Brisk response to light glabellar tap or loud noise, 4. Sluggish response to light glabellar tap. Glabellar tap, by the way, is when you are hitting the patient in this area. This area is painful. It can, once you will tap, it will be painful to the patient, and so he can open his eyes. You can check his response. Sluggish response to light glabellar tap or loud noise will take score of 5. And if no response at all, he will take score of 6. Now I will open the chat and I will wait for you to communicate with me. I will ask you and you will respond. In the previous slides, we mentioned that we have levels of sedation that are minimal sedation, moderate sedation, deep sedation, and general anesthesia. If you will merge modified Ramsey scale and you will tell me a patient with minimal sedation, what score could he have from such 6 scores? I see 2 answers. 1, 6, 3, 2, 1. There is no consensus on a specific number. 1, 2, 3. Type. I will stop now and we will take one by one. I am telling now minimal sedation. And score 1 is telling the patient is anxious, agitated, and restless. Do you think it is logic that a patient who is anxious is said to be anxiolysis, to be in minimal sedation? Of course not. So the point number 2, he is awake, cooperative, oriented, tranquil. This is more or less accepted to be mentioned as minimal sedation. I will ask the second question. I will go now to moderate sedation. Which number you can think about in such 6 numbers is dedicated for moderate sedation? Three, 4, 5, 3, 4. Nobody's mentioning 2. Not more. Type. Although I have mentioned that stage score of 2 can be accepted as a definition for minimal sedation, it is also accepted for moderate sedation because we mentioned that the patient accepts mechanical ventilation. If the patient is accepting mechanical ventilation, he is moderately sedated. It is not only a minimal sedation, because minimal sedation, he can communicate and interact with me very frequently. So mostly he cannot tolerate mechanical ventilation under moderate sedation, under minimal sedation. But also, semi-asleep responding to command is very accepted for moderate sedation. So the answer is 2 and 3 can be accepted as a moderate sedation. What about deep sedation? How can we assess a moderate, deep sedation on the scoring level? And now you can see that you can mention more than one answer for a same level. 6. No, I will not accept 6 at all, because 6 is no response. No response to pain, no response to anything. It means general anesthesia. It cannot be at all minimal, moderate, or deep sedation. But if you will speak about 4 and 5, well and good. 4 and 5 can be deep sedation. The point of my discussion with you now is what? That even though we have a score and we have a scale, it didn't give me the clear answer. Where is my level of sedation now? Patient is deep or not? You got my point? So I need another machine. I need another scoring system. I need another scoring system that tells me really where is my patient. And that's why we have invented the bispectral index machine. Bispectral index machine is, we will put electrodes on the forehead and it will monitor the electrical activity of the brain of the patient and will transform the waves into a score. So the number that I can get from the bispectral index is ranging from 0 to 100, depending upon how much active is the brain cells. This will give me clear number, and this clear number can be a range. For example, when we are telling that the patient is ranging from 0 to 100, normal awake patient will range from 90 to 100. Between 80 and 90, patient in anxiolysis. If between 60 and 80, moderate sedation. And as long as it is decreasing, the depth of sedation and anesthesia will be more and more. Of course, we are not planning to see a 0, because 0 means the flatline EEG, and this is dead body. What I need to say, that the bispectral index machine can help me to really understand where is my patient, even though it is a range. And sometimes the range is not so accurate, but at least it is more accurate than when we are speaking about sedation scale. The second item in monitoring is oxygenation. We can use the color of the patient and the pulse oximeter as indicator for patient oxygenation. The color is giving me only an idea. It shall not give me alone a clear, to be sure that the oxygenation of the patient is accepted or not. It detects the cyanosis very late. And when saturation is less than 80, and the 80, by the way, is too much low, I cannot wait till the patient gets oxygen saturation less than 80, and then I will realize that the patient is deteriorating. The pulse oximeter, if I will speak about the machine itself and how it works, it is an indirectly monitoring of oxygenation, oxygen saturation of the patient, and the change in the blood volume in the skin of the patient. It is producing a photoplasmogram. Photoplasmogram means a wave that can say there is increase in the blood volume and decrease in the blood volume, increase blood volume, decrease blood volume, increase blood volume, decrease blood volume. This will give me as an indicator of what? Yes, of the heart rate. The heart is pumping, so the increase in systole and the decrease in the diastole. So I will not only realize the oxygen saturation level, but also I will discover the heart rate of the patient. I just having some lag, and I need to confirm. Now, it is clear to you, the sharing. Please write in the chat. Do you see now the slides? Yes. So we will go back. What is the idea that we are depending upon in the pulse oximeter? The idea is that in my blood, I have several forms. One of them is called oxyhemoglobin, and one is hemoglobin, and one is deoxyhemoglobin. This is hemoglobin plus oxygen or plus carbon dioxide. Each one of the three forms is having different physical characteristics. It can absorb specific wavelength, and if I will give another wavelength of light, it will pass without being absorbed. So I have a sensor containing 2 or 3 light emitting diodes and a light detector, and we are putting them across the finger, toe, or ear lobe. After which I will let the machine give me specific wavelengths, specific calculated doses of the wavelengths that we know from the physics, and then we will compare the relative amount of oxygenated versus the deoxygenated hemoglobin by computing how much absorbed from this wavelength and how much absorbed from that wavelength. The normal range of oxygen saturation is 95 to 99. But take care, some patients who are COPD patients, their normal level of oxygenation is 84 to 94. And in case oxygen saturation or saturation of the blood will be more than 94, the patient will be in danger because their brain will not breathe if oxygenation is more than that. So the power of breathing will be affected in case the saturation is very high for such population of patients. The advantage of this machine is it is simple, non-invasive, it is measuring saturation and heart rate, and it has a tone, and this is very important. When the machine is working, I can listen to a beep. Beep means one beep, 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 beep. And maybe you will listen to toneless beeps that can be high-pitched beep, 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 or can be low-pitch beep, beep, beep. Our saturation machine, our pulse oximeter machine is having this kind of tone. In high-pitched, it means I am good saturation, I am high saturation. And in low-pitched sound, it will be low saturation. So even if I am not looking to machine, I am not seeing the number, I can tell you if the sound that I am hearing, it means good saturation or bad saturation. But the machine is not out of disadvantage because the machine is inaccurate in low SpO2, and there is a lag time between apnea and desaturation. And I will stop here for a while. Why we are telling that there is a lag between the apnea and desaturation? Apnea means there is no respiration. There is no gas exchange in the lung. Desaturation means that the oxygen that was pumped from the heart that reached the fingers is low in saturation. The circle of the hemoglobin, it is coming out of the heart, going to the lung, taking oxygen, and then going back to the heart and being shifted and pushed to the periphery. After that, the machine will calculate and compute and reach a diagnosis that this is low saturation or good saturation. The circle time can be 15 seconds from pushing bumping the hemoglobin to the lung, back to the heart, going to the periphery, and computing. It takes time. And that's why we are telling there is lag time between apnea and desaturation. The accuracy of the pulse oximeter is affected by several factors. As we mentioned before, that because there is blood in and blood out, and I am testing how much oxygenated and deoxygenated oxygenated hemoglobin, oxyhemoglobin and deoxyhemoglobin, and the relation between them. If I am having something that is affecting the perfusion of the finger, it will affect the capacity of the machine to sense properly. Like hypoperfusion, cold extremity, severe anemia. Such three things shall decrease the capacity of the machine to sense, is this lack of oxygenated and deoxygenated hemoglobin, or it is decrease in the perfusion of the limb. Of course, if my emitter and my receptor is not put in a good position, there is a malposition, of course, it is not put 100% in between the tissue of the patient, the skin of the patient is not 100% between both of them, it shall not read at all. Again, I am depending upon calculated pre-assessed doses of wavelengths of light. What if I am having a bright or ambient light from another source? The machine shall not know if the source available, the computed and calculated dose predetermined is affected by another source or not. The machine cannot say. So the result will be affected. Shivering of the patient. If the patient is having nail polish or henna or dirt, specific compounds like carbon monoxide and cyanide interferes with the normal readings of deoxyhemoglobin and oxyhemoglobin, and also methemoglobinemia. All such factors are affecting the accuracy of readings from pulse oximeter. How we can decrease the problems or increase our sensitivity of the readings we are getting from the pulse oximeter is by choosing appropriate sensor size and type, warming the extremity in order to improve the circulation, protect my sensor from the bright or ambient light source, removing nail polish or dirt from the digit if applicable, avoid placing on an extremity with arterial line because arterial line will make vasoconstriction in such limb, and in a limb that's having a blood pressure cuff or IV tourniquet, because repeating the blood pressure cuff in and out will be read as cardiac arrest or not, and sometimes desaturation during the journey of the pressure cuff reading or not. Putting a sensor on an extremity or digit that it is not moving extensively is my last thing in the to-do list. Oxygen saturation should be recorded prior to administration of supplemental oxygen and prior to initiating sedation. This is a very, very important item. I should know what is normal for this specific patient. In order to know what is normal for him, my measurement should be done before giving any supplemental oxygen or any sedatives that may affect the ventilation of the patient and his breathing circuit. So to know the baseline, I shall measure the oxygen saturation. If I will find a low reading for the patient without touching him, without interfering him, this I should think about what? This is COPD. If he is COPD, I will take care because I don't need his saturation to be raised above 94 at all. My pulse oximeter tone should all the time be on in order to early detect, by not even if I am not seeing the monitor, to early detect that the saturation is decreasing or not by listening to a variable changing, decreasing in pitch sounds of the pulse oximeter machine. Oxygen should be administered to all patients undergoing conscious sedation. This is my rule. Oxygen should be administered to all patients receiving sedation. Maybe I can give a nasal cannula starting by 2 liters. I can change the rate or mode of oxygen delivery. I can make it face mask with reservoir, according to the condition of the patient and whatever condition I am seeing in the patient now. Observe closely when you are dealing with patient with history of COPD, because he is dependent on the hypoxic drive in his respiration. The third item in monitoring is respiratory rate and pattern. The more deeper level of sedation, the lesser respiratory rate will be. Again, my baseline assessment for the normal or for the current situation of the respiration of the patient should be recorded and should be assessed and recorded. And after that, every 15 minutes, note and record the respiratory rate after that. Continually observe for adequacy of spontaneous ventilation and airway patency. I can reach this by auscultating, by watching the chest rise and fall, or by using a capnometry. Ventilation can be assessed by auscultation and can be assessed by capnometry, capnography. Capnography is a non-invasive measurement of partial pressure of carbon dioxide from the airway during inspiration and expiration. The machine is giving me end tidal CO2 level. It can give, because the end tidal CO2 level will be different from during inspiration and during expiration, inspiration, expiration. The machine can give me a respiratory rate also. This graph is minimally complicated, and we will try to simplify it for you now. We know that the patient has expiration and inspiration phases of respiration. His inspiration phase can be divided only in one stage. During inspiration, the patient takes air from the outside air and gets it inside the patient chest. If I will put electrode in front of the mouth and I will measure the carbon dioxide level during inspiration, it shall be related only to the CO2 level in the air, because there is no interference with the patient at all. It is only air that comes out from outside to inside, so it is dependent on the CO2 level in the outside atmosphere, and nearly it is negligible and it is zero level. But once the patient will finish his inspiration, he will start expiration. The expiratory level of CO2 will be dependent on what? On the level of CO2 that is coming, and on the from where this CO2 is coming now. My airway tree is composed of trachea, and above it is the pharynx and nasopharynx. There is no gas exchange inside this area. So what? Whatever I had inhaled from outside and I will start to exhale now shall be same level of CO2, because there is no gas exchange at all in such area. And so the first phase of expiration level of CO2 shall continue zero level, after which the mixing of the alveolar gas exchange that is full of CO2 and the dead space that was above it will lead to rapid rising of CO2. The slope of CO2 increases fast till all the dead space content of the air is lost, and only content of alveoli that is constant level of CO2 is there will reach. And so I will have the third level during the expiration, and it is a plateau stage. Plateau, that means CO2 is constant level till the patient will start his next cycle of respiration. The inspiration shall occur. Once inspiration will start, rapid, abrupt decrease in the CO2 level to reach a zero. So in this A graph, I am having 4 steps. 2 of them is zero, one during inspiration and part of the expiration. Then rapidly rising stage 2 expiration, then plateau in stage 3 expiration, and then coming back to the inspiration level. This is a normal capnography graph. Sometimes I am having patient that is having bronchospasm, patient asthmatic. How this bronchospasm will affect the diagram that I am getting from the capnography. Same inspiration, it is zero. Same first stage of expiration, it shall continue zero. But I am telling there is bronchospasm. Bronchospasm will lead to what? The mixing time from starting pushing CO2 from alveoli, mixing with the dead space and reaching outside the body will be prolonged. So the phase 2 of expiration will be prolonged. The slope of increase of CO2 will be less. And then it will increase slowly. Then suddenly the patient will start taking inspiration. And that's why I shall not see the third stage of expiration, that is the plateau. I will see only stage 2 and then inspiration. If I am starting with normal diagram, and then in the middle, I will find it doing triangular shape like this, this patient now has started to be bronchospasm. Mostly, he's starting to be feeling pain. And maybe this bronchospasm is due to the pain itself. So, even from the capnography, I am not only seeing the patient is breathing or not, his ventilation is not or not, good or not. I am also seeing my level of sedation is good or bad. Our step down for the monitors, the ECG and the heart rate, and after that the blood pressure. The ECG is giving me an idea about the rate, the rhythm, and ischemic change in the heart. We have 2 kinds of ECG machines. One is 3-lead ECG that is having only single trace of ECG, and the other one is 5-lead ECG, in which I can see several traces and lead 1, 2, 3. I can adjust several leads on the machine. Both of them, if we are speaking about rate and rhythm, equivalent. And also the locations on the chest wall, if I am putting in a good place or deviated minimally, both of them will show me a trace of ECG. But if you want to trace the ischemic change in the heart, you cannot depend upon the 3-lead ECG at all. It is not designed to monitor the ischemia accurately. And also, if you are using a 5-lead ECG and you are not putting electrodes on the proper places that was intended and drawn on the leads, the assessment of ischemia shall not be accurate. I cannot depend upon inverted T or the configuration of the QRS complex unless I am using 5-lead ECG and the locations of the electrodes are in the proper places. Our last monitor is the blood pressure monitoring. Again, we will say that knowing the baseline measurement and recording it before we start sedation is needed. Assessing and documenting the blood pressure 2 to 3 minutes after administration of any drug. And when the patient condition has been changed, or at least every 5 minutes, should be assessed and documented. So when should I monitor and document my blood pressure? At least every 5 minutes, or if you realized at any time that the patient condition has been changed, or giving 2 to 3 minutes after giving a sedation dose, and then assessing if it has affected the blood pressure at more or less than expected. Because I am expecting the blood pressure to be modified or changed by sedation, but to some level, no problem. In another level, I should interfere. By that way, if I will monitor my patient well for his conscious level, his oxygenation, his ventilation, his cardiovascular functions, I can draw a picture to my patient. I can realize if my patient is in which level of sedation, if he's deteriorating or not. And if I will realize if deteriorating or not in the proper time, I can prevent more deterioration. I can prevent complication to occur in such patients. That's why my first lecture was designed to speak about monitoring, because this is the only way to prevent complication from being occurred. And I know that the complication rate during sedation is very high, and I should do my best not to let it occur. Before I go to the next lecture, I will have few seconds or few minutes to receive question from you. If you have a comment, give me now. If not, keep it till the last of our lectures. Any question? So I will proceed. This is the most heavy lecture in our day, because pharmacology of sedatives and antidotes will have a lot of doses, a lot of mechanisms of action. I am not intending from my lecture now to give you or to let you understand and memorize all the doses. You will find the doses in this lecture taken from the PDF that I told you the company will give you after finishing the course. So we will speak about categories of sedatives. We will speak to know the basic information about each medication we are using, and in case this medication is having an antidote available, I will tell you about. First, what are the categories of sedatives? First group, benzodiazepines, which contains the two major medications that are available in all hospitals, either private or MOH, midazolam and diazepam. The second big category is narcotics, morphine, betadine, fentanyl. Those are the most used frequently medications in the narcotics. And there is another group that is others, like propofol, ketamine, and chloral hydrate. Because all the 8 medications we are using frequently in our practice, we will depend on them. The rare things that we can use, I shall not go through. Let's start with benzodiazepines. Benzodiazepines are the most widely used drugs for sedation. It is providing several therapeutic effects, including sedation, anxiolysis, amnesia. It has anticonvulsant property, and also there is something called spinally mediated muscle relaxation. It probably works on the limbic system and amygdala in the brain, where the fear and anxiety and apprehension are located. So when I am telling that the brain centers that they are affecting is dealing with the anxiety and apprehension, it means it will lead to such a combination of effects. We have special concerns when we are dealing with benzodiazepines, that if a patient is chronically using H2 blockers like cimetidine or ranitidine, they are highly susceptible to benzodiazepine overdose. And so there will be increase in the sedative effect of any benzodiazepine. Also, when we are combining narcotics with the benzodiazepine, both of them shall have a great potentiation on the respiratory depression action. Let's take medication by medication. We will speak about midazolam. Midazolam is a water-soluble substance that has cyclic imidazole and diazepine rings. This structure is giving me a unique physico-chemical characteristic. When we are speaking about level of pH less than 4, the ring is open, and this is a water-soluble state. And when a pH is above 4, the ring closes and it becomes lipid-soluble. The pH inside the patient body is above 4. The pH in the ampoule is less than 4. So the medication itself in the ampoule is water soluble. But once I will inject in the body and I will change the pH, it will become more lipid soluble, and so it can crosses the blood-brain barrier easily. So I am having from midazolam different kinds of states. I can have oral, I can have injection. Oral is having a rapid absorption, but only 50% of the dose given orally will reach systemic circulation because it is having first pass hepatic metabolism by 50%. Also, midazolam is extensively bound to plasma protein. It is 98% bound to plasma protein. And that's why, for such two reasons, it has a short duration of action in case you are dealing with single dose of midazolam, because it has a high lipid solubility, so it will be distributed to the adipose tissue and fat and will be removed quickly from the brain. So we have a rapid redistribution from the brain to the inactive tissue sites, as well as rapid hepatic clearance. Take care, I mentioned here what? The short duration is for single dose midazolam. When we are speaking about elderly, there will be a prolonged duration of action. According to the route of administration, the onset of action, the peak effect, and the duration of action will be affected. In the intravenous route, the onset of action is after 1 minute. The peak effect is after 3 to 5 minutes. And duration of action is ranging from 15 minutes to 6 hours. Oh my God, what is this? why we have a very wide range of action, and why I mentioned that the short action is related to single dose of midazolam. It is the same. I am having the medication that is lipid soluble, and it will be redistributed fast from the brain to the adipose tissue after single dose. But if you will give repeated doses, adipose tissue will be saturated after a while, and whatever you will give after that shall not be redistributed from the brain. It shall continue available in the brain up to 6 hours. So the 15-minute duration is for single dose, and repeating the doses shall prolong the duration of action up to 6 hours. If you are speaking about intramuscular route, the onset of action will be little prolonged, 5 to 15 minutes. The peak effect shall be 15 to 60 minutes. And the duration of action shall be 2 to 6 hours. Because during the intramuscular, I am giving higher doses. And I will wait till the muscle is saturated with the medication, because the muscle contains adipose tissue also. And then it will be distributed to the blood. The peak effect shall be little prolonged more than the intravenous. And the duration of action will both, in both conditions, single dose or higher doses, repeated doses, it shall be more duration of action. By same thinking, the oral route, the onset of action will be less than 10 minutes. The peak effect will be 30 minutes, and duration of action is 2 to 6 hours. How to give midazolam? I will dilute the midazolam with D5 water or normal saline till I am reaching a concentration of 0.25 milligram per ml. Then I will administrate this constitution no more than 0.5 milligram over 2 minutes. I am giving slowly, and I am waiting for some time for the medication to work in order to realize if I need more doses or not. The recommended dose in adult is initial dose of 0.5 milligram over 2 minutes, and wait 2 minutes to determine the effect. And then I will titrate my doses till I reach my desired effect state. What is the desired effect state for moderate sedation? It is having a slurred speech. What is meant by slurred speech? It is also called heavy tongue. What is this? The patient, we said before, in moderate sedation, he can respond to your verbal stimulation. You will ask him, he will answer you. In minimal sedation, if you will ask, he will answer as if he is awake like now. I am speaking fluently and fast. But if I am moderately sedated, my response will be heavy tongue, like whatever I am telling now. He's telling something, and he knows well what he's telling, but his tone and his speed of speech is less. Generally, I should not exceed 3 milligrams. Geriatric and pulmonary and hepatic impairment patient will affect my doses, because I will decrease the initial dose 0.5, 0.25 to 0.5, and I shall not exceed 2 milligrams, not 3 milligrams, like in adult who is not having any other anomaly or problem in the respiratory and liver. If you are speaking about pediatric, our doses is calculated according to the body weight. So the dose is 0.025 to 0.05 milligram per kilogram over 2 minutes. Maximum dose is 0.1 milligram per kilogram. Our second medication in the benzodiazepine category is diazepam. Diazepam differs from midazolam in several things. It is highly lipid soluble. It is widely distributed throughout the body after administration. It easily crosses both the blood-brain barrier and the placenta, and it can be excreted in the breast milk. As you see here, diazepam is only lipid soluble. It is not like midazolam. In the ampoule it is water soluble, and in the body it is lipid soluble. No, it is starting from the beginning, it is lipid soluble. That's why, and because it is irritant, I cannot give intramuscular. I have only intravenous and oral. Intravenous, it is 1 to 5 minute onset of action, 3 to 5 minute peak effect, and duration of action is 2 to 4 hours. We don't have 15 minutes like midazolam. Orally, it will start 15 to 60 minutes. The peak effect will be reached after 1 hour, and the duration of action is 3 to 6 hours. Comparable to midazolam, you will find midazolam is too high, better option than diazepam. If I am having both of them in my custody, and you will ask me, what can I give? I will definitely choose midazolam, because at least it is giving me a duration of action that could be less than a couple of hours by using intravenous route. Dilution of diazepam is only by normal saline. If you will compare to midazolam, you will not find D5 water can be used. Only normal saline. And don't mix it with any other medication. The adult dose is 1 to 2 milligram intravenous increment every 2 minutes, titrated to my desired effect, that is the same slurred speech. Generally, within 1 hour, I shall not increase what I am giving more than 10 to 20 milligrams. Again, in the pediatric dose, it is calculated according to weight. It is 0.1 to 0.3 milligram per kilogram. We have potential adverse reaction to diazepam. I mentioned quickly before that it is an irritant medication that cannot be given intramuscular. Why? Because it can cause phlebitis at site of injection. It can cause bradycardia, hypotension, respiratory depression, apnea, agitation, confusion, hiccup, diplopia, rash, and urticaria. A lot of potential adverse reaction is there. And even I cannot give intramuscular. And even if I am giving intravenous, I should avoid extravasation of the drug because it is causative to tissues. Do we have antidote for benzodiazepine? Yes, we have. What are the antidote? It is called flumazenil. Flumazenil is a specific benzodiazepine antagonist that it can be used to completely or partially reversing the sedative effect and managing overdose of the benzodiazepines. It can be given intravenous bolus or infusion. There is no oral, there is no intramuscular route. The onset of action is 1 to 2 minutes. The peak effect is 6 to 10 minutes. The duration of action is 45 to 90 minutes. And here I will stop for a while. If you remember, the duration of action of benzodiazepines, both midazolam and diazepam, can reach 6 hours. And the maximum duration of action for flumazenil, I am telling it is 90 minutes. It means what? I can reverse the action of the benzodiazepine by flumazenil, but only till the 90-minute window finishes. After which, if the dose of benzodiazepine or the concentration of benzodiazepine in the blood still high, resedation should be considered or can occur. Resedation can occur after the 90 minutes. When I am giving flumazenil, I will give initially 0.2 milligram over 15 seconds to 1 minute. I will give 45 seconds to check if the response is there or not. I can repeat in 1 minute interval until either two things. Either I will reach 1 milligram dose and still no response, or I can reach that my patient recovered. If I will reach 1 milligram dose and no response, it means what? Maybe there is another reason for deterioration or for the condition that I had been reversing by flumazenil, and it is not from the medication. I need help. I need another personnel to attend with me to check what is going wrong to help the patient. This is in the bolus category. In the infusion category, I can give 30 to 60 microgram per minute, or in case I am dealing with pedia, it will be 0.5 to 1 mic per kg per minute infusion, and totally I shall not exceed 3 milligram per hour. Special concern in pediatric population. I am giving initially bolus dose 0.01 milligram per kilogram. I shall not exceed 0.2 milligram maximum. I will give this initial dose 15 seconds to 1 minute over 16 seconds to 1 minute. I will wait again 45 seconds to 1 minute and repeat. The cumulative dose that I shall not exceed is 1 milligram maximum and 0.05 milligram per kilogram. If there is no response after this 1 milligram maximum, I will call for help. The infusion again is 0.5 to 1 mic per kg per minute. We have a special concern generally for flumazenil, that flumazenil by itself can cause seizures in patients with chronic dependence on benzodiazepine. Addicts on benzodiazepines, if they will receive flumazenil, they will have seizure-like effects, withdrawal symptom. Because I told you before that the action of flumazenil is maximally 90 minutes, I shall monitor my patient more and more time, and I will monitor specifically for resedation after that. Administer flumazenil in large vein because it can cause pain and inflammation at site of injection. Flumazenil itself can lead to overdose, resulting in anxiety, agitation, and convulsion. That's why when we are giving specific small incremental doses and giving the proper time for them to work before I give the other next dose, and not exceeding specific dose because of this, because it can cause anxiety, agitation, and convulsion. Take deep breath, inhale and exhale. Inhale and exhale before we go to the second category of sedatives, that is narcotics. Narcotics, we mentioned before, 3 medications. The 3 medications are morphine, betadine, and fentanyl. Before we proceed to the specific 3 medications, we will speak generally about narcotics. In our body, we are having some endorphins. Some endogenous opioid. The endogenous opioids in our body are three groups: endorphins, enkephalins, and dynorphins. Those are naturally occurring three groups of endogenous opioids. Each one of them can affect several opioid receptors: alpha, sigma, delta, gamma, kappa. Those receptors are distributed in different tissues in the brain, spinal cord, other GIT like this. And if you will activate this kind of receptor, you will have specific physiological effects. Each category of the endogenous opioids are having different effects on every kind of receptor. The mu is affected more by endorphins, less than dynorphins. The delta is having equal effect by endorphins and enkephalin, but less by dynorphins. The kappa is maximally affected by dynorphins and not affected by endorphins and enkephalins. I don't concentrate much in this issue, but I am telling that each effect can be different from each category of endogenous opioid, and according to the receptor it is working upon and the location of the receptor, the effect shall be. The mechanism of action, generally, it is reducing the cyclic AMP, decreasing the calcium channel inhibition, decreasing the neurotransmitter release, and decreasing the neuronal excitability by affecting the potassium channel and stimulating it. So it is decreasing the calcium channel and increasing the potassium channel and reducing the cyclic AMP. All of this will lead to what? Overall inhibitory effect on the cell. According to the location of the cell, the action shall be. It can be analgesia. It can be sedation. It can be on post-operative nausea and vomiting on the GIT tract. It can be constipation also on the GIT tract. On ventilation, it shall lead to ventilatory depression. Mu receptor in the ventral medulla inhibit the stimulatory input of chemosensitive neuron in the respiratory center, leading to ventilatory depression. Marked tolerance to ventilatory depression opposed by pain and stimulation. And so whenever the patient in recovery room or patient is post procedure, there is less pain, and so properly ventilated patient during the procedure can lead to post-operative or post-procedural apnea due to such effects. On cardiovascular system, there is a minimal effect on cardiovascular function in awake, healthy subjects. But if I am having a large dose or patient with vagal stimulation, bradycardia can occur. Reversal of bradycardia is by atropine. Hypotension and histamine release can be more seen during morphine use. Inhibition of sympathetic outflow, blocking stress response can lead to more cardiovascular effect to appear. Pruritus and muscle rigidity, specifically more and more muscle rigidity shall be in fentanyl use. If we will go one by one and we'll speak about morphine specifically, morphine is having a rapid absorption and wide distribution and rapid clearance from plasma. Clearance is mainly by hepatic biotransformation, 70% as a first pass metabolism, primarily 3-glucuranoid and also 6-glucuranoid. Both are outcome of metabolism in the liver. The 3-glucuranoid is an inactive, but the 6-glucuranoid is highly active material. So even though it is metabolized in the liver, it is having a sedative effect also. The metabolites after that will be cleared by kidney. Relatively hydrophilic drug. Hydrophilic drug. So the CNS penetration and exit are slow. And this accounts to the slow onset and long duration of action. Long duration of action can be reached by several mechanisms. One of them is the 6-glucuranoid metabolite from the liver is having a sedative effect. And the other one is relatively hydrophilic. We have intravenous, intramuscular, and oral routes. Intravenous, it is less than 1 minute onset of action, 5 to 20 minutes peak effect, and duration of action is 4 to 7 hours. Intramuscularly, it is 5 to 10 minute onset of action, 30 to 60 minutes peak effect, and 4 to 7 hour duration of action. Orally, within 1 hour onset of action, 1 to 2 hour peak effect, 6 to 12 hours duration of action. As you see, all the time I am having long duration of action, and all the time I am having longer peak effect from whatever route I am speaking about, except the IV, يعني more or less it is acceptable time. How we are giving? In adult, I will give 2 to 10 milligrams intravenous diluted in sterile water or normal saline. Must be given slowly titrated to individual response, that is the slurred speech. Dose should be decreased in elderly and debilitated patients and in patients with renal or hepatic impairment. I can repeat every 15 minutes, and I shall not increase the dose more than 10 milligrams in 60 minutes. When we are speaking about pediatric population, dose of 0.05 to 0.1 milligram per kilogram titrated to the effect. The second medication is fentanyl. Fentanyl is rapidly absorbed, widely distributed, moderately rapid hepatic clearance, more than 60% first pass metabolism to inactive metabolite. It has no 6-glucuronide like morphine. It is extremely lipophilic. That's why it rapidly crosses the blood-brain barrier, other membrane barriers. So the effect is parallel change in plasma concentration. The fat solubility means that the drug can be used in multiple routes. Useful analgesic effect can be transdermal, patch, intranasal, buccal mucosa. I can use it as lollipop for children. Our routes in the intravenous, it is less than 1 minute onset of action. Peak effect 5 to 15 minutes. And the duration of action is 30 to 60 minutes. Intramuscularly, it is 5 to 8 minutes onset of action, 15 to 20 minutes peak effect, 1 to 2 hour duration of action. Transdermal, 5 to 15 minute onset, 1 to 2 hour peak, and 1 to 2 hour action. As you see, such a profile is too much better than the morphine in case I am giving sedation for a shorter time procedure. How to give? 25 200 mic slowly intravenous over 1 to 2 minutes titrated to individual response. Dose should be decreased in elderly and debilitated patients and patients with renal or hepatic impairment. And for children, it is 0.5 to 2 mic per kg titrated to individual response. The last medication in the narcotic group is the betadine. Take care, betadine is having several names in the market. You can say meperidine, Demerol, and betadine are all the same medication. It is the first completely synthetic opioid. It has 1/10 of the potency of morphine. That's why the ampoule in morphine, you will find it 10 milligram, but the ampoule of betadine can be 50 or 100 milligram per ampoule. Metabolism is by hydrolysis, and then conjugation, then demethylation into normeperidine. Normeperidine is having an opioid activity also, and it is neurotoxic and excreted by kidney. That's why in case we are having patients with renal failure and we will give repeated doses of betadine, accumulation of normeperidine can lead to seizure. And there is another effect that is fatal. It is interaction with MAO inhibitor, monoamine oxidase inhibitors. And this interaction can be severe and possibly fatal excitatory state of hypertension, tachycardia, delirium, seizure, and hyperpyrexia. So never ever to give betadine for any patient known to take MAO inhibitor medication. The routes of betadine, it can be intravenous, intramuscular, or oral. Onset for intravenous after 1 minute, peak 5 to 20 minutes, duration of action 2 to 4 hours. Intramuscularly, 1 to 5 minute onset of action, 30 to 50 minute peak effect, duration of action is 2 to 4 hours. Orally, it can be onset of action 15 to 45 minutes, peak effect 60 minutes, and duration of action is 2 to 4 hours. For dose, adult is 25 milligrams slowly intravenous titrated in 25 milligram increments to individual patient response. The total dose of 100 is the maximum in 60 minutes. Those should be decreased again in elderly and debilitated patients, in patients with renal, especially renal and hepatic impairment, not only for overdose but also for seizures, and patients with hypothyroidism. Pediatric dose is 1 to 1.5 milligram per kilogram titrated to the individual response. As we mentioned before, our contraindication disaster shall be with MAO inhibitors. Do we have opioid antagonists? Yes, we have. Our opioid antagonist here is called naloxone, and also another medication that called naltrexone. Naltrexone we shall not speak about because it is being given in heroin addiction detoxification, not for sedation antagonist. Mostly we will give naloxone. It is pure competitive antagonist on the level of mu, kappa, and delta receptor. Highest affinity is the mu receptor. It rapidly reverses the opioid overdose, but its effect is short. And so also, like the antidote of benzodiazepines, we will monitor our patient from being re-necrotized again. The dose of naloxone will work. It is only intravenous. It will work after 1 to 2 minutes. the peak effect 5 to 15 minutes, the duration of action is 1 to 4 hours. Even though it is 4 hours, some medications can be longer than 4 hours, and so re-narcotization could be there. The initial dose is 0.04 milligram to 2 milligram, titrated in small incremental doses. How will I give? I will dilute the ampoule. The ampoule contains 0.4 milligrams. I will dilute the ampoule in 10 cc total volume. I will give 1 cc every 2 to 3 minutes. If no response, when I reach 2 milligrams is 5 ampoules, I will call for help. Pediatric dose is 0.01 milligram initial dose and can be repeated twice. If no response, what will I do? Call for help. Adverse reaction of naloxone is there and is serious, and so I shall not give unless I need to give. Naloxone can lead to pulmonary edema, hypotension, hypertension, arrhythmias, ventricular tachycardia, and even ventricular fibrillation. It can lead to excitement, condition, tremors, seizures, because it is reversing the analgesic effect, and so the patient will be in severe pain if you are reversing the analgesia fully and fast. So the rate of giving naloxone and need for giving naloxone should be judged properly and manipulated judgelessly. Our third category are others. In the others, we mentioned the propofol, the ketamine, and the chloral hydrate. All the medications in the other category has no reversal agent. We have only reversal agent for benzodiazepine and narcotics. The propofol is an intravenous agent that contains alkyl phenyl group. It is affecting the GABA receptors. Its elimination is intrahepatic and extrahepatic, and so we have a very rapid clearance and awakening for propofol. It can decrease the intracranial pressure and the cerebral perfusion pressure and the mean arterial pressure. The ampoule is 1% solution. It has soya bean oil, glycerol, and purified egg phosphatide, and it doesn't contain material that prevents bacterial growth. It contains egg yolk, and it doesn't contain a material that prevents contamination of bacteria and flourishing of bacteria. The pH of the ampoule is 8.5 and the pKa is 11. It is isotonic, compatible to be diluted by the 5% dextrose and normal saline. It can be stored in ordinary room temperature, highly lipid soluble, poorly water soluble, and it has no antimicrobial preservative. So once I open the ampoule, opening the ampoule should be under complete aseptic technique, so no bacteria can contaminate. Plus, the maximum allowed time for opened ampoule is 6 hours, after which I should discard. Propofol can lead to hypotension, negative inotropic effect, vasodilatation, bradycardia, seizure-like activity, myoclonus, and respiratory depression and apnea. If you will tell me, you mentioned a lot of complications, a lot of bad outcomes of propofol, why you are discussing with us? I am discussing because of this profile. The onset of action of propofol is 40 seconds. The peak effect of propofol is 1 minute. And the duration of action is 5 to 10 minutes. It is ultra short medication. It is ideal for sedation. But it was not intentionally used medication because of sedation. It was used because it is general anesthetic. Using of general anesthesia medication can lead to very deep sedation easily, and even general anesthetic situation if you didn't use the medication judiciously. You have to take all your precautions in case you are using propofol or ketamine, because both are general anesthetics. In case you want to use, how you will use, I will give 25 to 50 milligrams. And this is equivalent to 0.5 to 1 milligram per kilogram in pediatrics. Intravenous administration in 10 milligram increment over several minutes. Or I can use 0.5 milligram per kilogram bolus over 3 minutes, followed by infusion of 25 to 75 mic per kg per minute. I can use incremental doses, and I can use initial dose, then infusion. For pediatric, 0.5 to 1 milligram per kilogram infused slowly and titrated to the desired effect. Adverse actions of propofol is anaphylactoid reaction. In case I am prolongedly using in pediatric population, it can lead to metabolic acidosis and heart failure. I can find pain at site of injection, bacterial contamination of the solution, hyperlipidemia, hypercarbia. Our second medication in the others group is ketamine. This is the second general anesthetic medication that can be used for sedation. It causes dissociative general anesthesia. It is affecting the NMDA and opioid receptor, and it interacts with the limbic and thalamic system. It is producing what is called cataleptic effect state, in which the patient is dissociated from his surrounding environment. The patient can look like being awake. The patient can open his eyes, can make movement from his tongue and mouth, and he is under general anesthesia. Even the patient is blinking his eyes and he is a general anesthesia, yes. How will I differentiate between the levels of sedation if the patient is blinking his eyes and I cannot comment he is awake or not? By painful stimulation. If he is moving his hand when I am touching and doing some pain, well and good. But if he is not responding to painful stimulation, he is under general anesthesia. Ketamine can produce intense analgesia without causing hypotension, and this is a very good reason to use in bleeding patient, in hypotensive patient, in shocked patient. Shocked patient, I need to sedate. Can I give narcotics, benzodiazepines, propofol? No, because all of them will lead to high level of hypotension more and more and shock more and more. The only medication can be given at that time is ketamine. And sometimes we are combining some ketamine and some other medication to counteract the effect of hypotension of the benzodiazepine and narcotics. Ketamine will result in dose-related increase in heart rate and blood pressure. Ketamine may adversely affect the pulmonary vascular resistance. It will cause pulmonary hypertension. An additional effect that may influence the airway patency, it is increasing the oral secretion. How increased oral secretion can affect airway patency? By having the saliva touching the vocal cords. If saliva will touch a vocal cord will close. Dose of administration of ketamine, it is 0.5 used and very widely causing problems is the chloral hydrate. Chloral hydrate is having a pure sedative hypnotic with no analgesic property at all. It may produce a state of disinhibitionism and agitation because the patient has painful stimulation. It is rapidly absorbed from the GIT tract. Bioavailability from GIT is 100%. Following absorption, it is metabolized in the liver to an active ingredient called trichloroethanol that has a CNS depressant action. Orally, it will work after 15 to 30 minutes. The peak effect is 30 to 60 minutes. Duration of action is very, very, very prolonged. In case you are speaking about pediatric population, toddlers are 10 hours or more, neonates are 20 hours or more. We has no intravenous or intramuscular route. When you are giving, it is 25 to 100 milligram per kilogram, up to 1 gram dose, maximum 2 grams in 2 divided doses. And the adverse reaction is desaturation, respiratory depression, airway obstruction, agitation, ataxia, vomiting, cardiac dysrhythmia, increased risk of direct and indirect hyperbilirubinemia and kernicterus in neonates, metabolic acidosis with repeated dose, especially in neonates. The contraindication of chloral hydrate is preterm and term neonates. If you need repeated doses, if you will give only single dose, you can use. Patient with significant hepatic or renal disease, patient with cardiac dysrhythmia, patient previous idiosyncrasy or hypersensitivity to the medication, and patient with porphyria. All are contraindications for chloral hydrates. Again, we have 3 categories. 2 of them has antidotes, and 1 of them doesn't have antidotes. Specific concerns are related to the population without antidotes, because I cannot reverse if I will give overdose or if the patient will be very sensitive to the medication. That's why I need to be very familiar with the others group, very familiar and very cautious in repeated doses, so that I will not catch overdose or complication from such group. I will open the floor now to the discussion. If you have questions, ask me now. Another question I will ask if I don't have question from you now. Do you think You are now competent to start a third heavy lecture, or you want to take 5 minutes rest? I know the pharmacology is heavy, and mostly your brain will be saturated with information in such lecture. Should I give you 5 minute rest, or I will proceed to the airway? 5 minutes. طيب, please, I will stick to 5 minutes. Now it is 10:42. I will make it 8 minutes. So 10:50 sharp, I will start my next lecture. Okay? To be clear, I will not wait. 10:50, I will start my lecture. Thank you, and I will join you 10:50. Can you hear me well? Voice is clear. Nice. As we said, we will start 10:50 sharp. I will start now my third lecture, the airway management, in which we will discuss the airway anatomy and physiology. We'll speak about history and airway evaluation, basic airway manipulation and advanced airway manipulation, and in the last, there will be specific concerns for pediatric population. As all of us know, that the anatomy of the respiratory system can start from the nasopharynx, nose, mouth, larynx, trachea, divided into bronchioles and alveoli. The lung itself is covered by pleura and thoracic cage and the diaphragm. Those are the components of the airway in the body. Starting from nose and mouth, it is warming and moistening and filtering the air, after which the pharynx can be subclassified into oropharynx and nasopharynx, epiglottis, then trachea, larynx. After that, the cricoid cartilage and the ordinary tracheal rings that will divide to bronchi. The lungs are covered by visceral pleura and parietal pleura, and in between the interpleural space, finally, the diaphragm. If you will see how we are breathing, we are taking inspiration and expiration. Inspiration is inhalation. It is active process in which the diaphragm and intercostal muscles contract, leading to increasing the size of the thoracic cavity. The diaphragm is moving slightly downward and the ribs are moving upward and outward. This will lead to airflow into the lung due to negative pressure of the chest cavity. The expiration is a passive process in which the diaphragm and intercostal muscles relaxes, decreasing the size of the thoracic cavity. The diaphragm will move upward and the ribs will move downward and inward. The airflow out of the lung due to positive pressure inside the chest cavity. So we have active process, that is the inhalation, and passive process is the exhalation. If we will speak about the physiology of the respiration, we will speak about some terminologies like oxygenation. Oxygenation means what? The blood and cells become saturated with oxygen. The terminology hypoxia, it means inadequate oxygen being delivered to the cell. If the body has such a condition, it will start to interact. Some signs shall appear on the patient telling I have hypoxia. What are such signs? First, there will be increase in the heart rate. After that, there will be decrease in heart rate. So heart rate shall start its effect that tells I am in hypoxia with tachycardia, then bradycardia. Altered mental status. It is also an early sign. So early signs of hypoxemia are tachycardia and altered mental status. Late, it will be decreased in heart rate and agitation. Blood pressure is equivalent to heart rate. It is starting with increased or elevation in the blood pressure followed by decrease in the blood pressure. Cyanosis is often a very late sign of hypoxia. When we are speaking about the gas exchange on the alveolo-capillary level, we have oxygen-rich air that is entering the alveoli during inspiration. Also, we have oxygen-poor blood in the capillaries passing through alveoli at the same time. And that's why oxygen will enter from the capillary, oxygen will enter to the capillary, and carbon dioxide will leave capillary and go to alveoli. But if we are speaking about the cellular level, capillary cellular level, you will find that the cells is giving up carbon dioxide to the capillaries, and the capillaries will give oxygen inside the cells. This quickly how it is being the physiology and anatomy of the journey of the oxygen in our body. Our very important topic now is how to assess the airway. How can we identify if we will give sedation to this patient, he can be airway compromised or not? Should we call for help before we start sedation or not? Should we prevent ourselves from giving sedation and give the sedation job to another personnel or not? How we can identify is by taking past medical history and doing airway evaluation. The medical history that can let us think about that we may face difficult airway are rheumatoid arthritis, ankylosing spondylitis, cervical fixation devices, thyroid or major neck surgeries. And that's why after taking history, we will assess the airway by several techniques. When I am assessing the airway, I am assessing 4 things in the mouth, 3 things in the oral cavity, 4 things in the neck. I can use some and or all according to my situation, according to the policy of my hospital. What I am looking for in the mouth, I said 4 things. Length of upper incisors. The longer the incisor, the more difficult to intubate the patient if needed, because it will obstruct my vision or to the vocal cords. The relationship of the maxillary incisor to the mandibular incisor. Normally, maxillary incisor or upper low teeth is little in front of the lower incisors in the mandible. If the lower incisor is at the same level of maxillary incisors, or too much backward or too much in front of the maxillary incisors, it means we have a problem. Maybe we'll face difficult airway. The third thing we are assessing in the mouth is the ability to progant the mandible, the ability to protrude the mandible and make the lower incisors in front of the upper incisors. If you cannot progant your mandible, if you cannot bring the lower incisor in front of the upper incisor, it means the mobility and flexibility of your mandible is low. And this tells me that if I will need to intubate, I may be in trouble. The last thing is the inter-incisor distance. When I am asking the patient to open his mouth fully and then checking the distance between the upper incisor and the lower incisor, the bigger the distance, the easier the airway. The lesser the distance, less than 3 centimeters, is an indicator of difficult airway. So this is the first thing I can assess is the mouse itself, and I can see 4 things in the mouse. What about the oral cavity beyond the mouse? What shall I check? I will check the visibility of uvula by using Malambati classification, and we will see it now after this slide. I can see the shape of the palate. High arched palate will make the airway difficult if I will need to intubate. And I can check the compliance of the mandibular space. Let's go to Malambati classification. Please, I need you to come out of this slide while you know very well how to check the Malambati classes. First, how the patient is located or sitting, or the position of the patient. The proper position for patient to check Malambati is to let the patient sit up. Then open his mouth fully. Then protrude his tongue out of the body completely as much as he can. Those are the 3 criteria for successful Malambati classification scoring. First, sit up. Second, open your mouth fully. Third order is protrude your mouth, protrude your tongue. Then I will look inside the cavity. I will see what? I will see the uvula, soft and hard palate, pillars of the tonsils, or pieces or parts of such content. If I am seeing all what I have mentioned, the uvula, the pillars, soft palate, and hard palate, it is the easiest airway, and it is called class 1 Malambati. If I am seeing only part of the uvula, base and soft palate, and pillars I cannot see, this is Malambati class 2. If I am seeing only soft palate and hard palate, and I am not seeing any part of the uvula, and of course at that time I shall never see pillars, tonsillar pillars, this is class 3. If I am only seeing hard palate, it is class 4. One will ask me, how will I differentiate between soft palate and hard palate? Maybe I can see piece of soft palate and I can consider as hard palate. Yes, you are absolutely right. And I have a good news for you. If class 3 or class 4, it doesn't matter with me to differentiate between them, because both are difficult airway. And also, class 1 and class 2, both are easy airway. Type. To make it more simple for you, my landmark to differentiate between difficult airway or easy airway is piece of uvula. If you are seeing either piece of uvula, that means class 2, or full uvula, that is class 1, in any situation of them, it is easy airway. But if I don't see any piece of uvula, it means it can be either 3 or 4, and both of them are difficult airway. So when I am letting the patient sit well and open his mouth fully and protrude his tongue, I am looking for the uvula. Uvula, I can see part of it, Malambati 2. All of it, Malambati 1. I don't see at all, it is either 3 or 4, and that's it. This is difficult airway. Clear? Type. The last thing in the neck. What shall I check? I can check 4 things. Thyromental. or thyrosternal distance, length of the neck, thickness of the neck, range of movement of the neck. Those are the 4 things that I will see. If you can see special situations like such slides, why I told in the past history of ankylosing spondylitis, it is difficult airway because we have abnormal adhesions and rigidity in the neck. The patient cannot extend or flex his neck, cannot move. I cannot manipulate the airway. I cannot extend the neck. I cannot flex. I cannot manipulate airway means if I want to intubate, I will be in trouble. Another picture of ankylosing spondylitis. Here, you see the patient even on the bed flat, he cannot put his neck on the pillow. It is fixed like this. And this patient is having a bilateral jumped facets of C4, C5. If you will try to manipulate the airway with minimal force, maybe it will have this will be broken neck. Maybe you will cut his spinal cord. Rheumatoid arthritis also is another problem. We have subluxation in the atlantoaxial joint that if you will manipulate the neck hard, you can also transact the vertebral column and patient will be quadriplegic. If you see a patient with thyroid scar, it means he did operation in such area. Maybe fibrosis is there. Fibrosis can make the area rigid and can make deviation of the airway, can make the trachea not in the proper place, or you cannot move it much. Morbid obesity and short neck and very thick neck like this here, I cannot see the neck. I cannot find landmarks. Kyphosis can make the curvature of the airway fixed, and I cannot move much, and I cannot see if I am trying to intubate. Pierre-Robin syndrome in pediatric and in grown-up adult with Pierre-Robin syndrome from pediatric, you will find micrognathia, retrognathia. What is the meaning? That the lower incisors are very back than the upper incisor, and the mandible itself, the anatomy of the mandible is too small. Tracheal colon is having the same pathology, the micrognathia, retrognathia, protruding upper incisor too much in front of lower incisor. If I will try to intubate, I could not, or maybe I cannot intubate. This is an adult who was tracheal colon in children. While she was a children, there is severe retrognathia, protruding of upper incisor, reduced thyromental distance, all things that can say we have a difficult airway. If you saw a patient with epiglottitis, there is inflammation in the vocal cord, inflammation of the larynx, pharynx. You will see a picture like this. Where can I intubate? How can I intubate? What size I can intubate? It will be disastrous. Acromegaly. Also, there is distorted airway anatomy. Morbid obesity. I can need, sometimes we need endoscopic intubation, fiber-optic intubation for such patient while he is fully awake. I am giving him local anesthesia of the airway until I intubate and he is fully awake. Then I will sedate or give general anesthesia. When we are seeing limited movement of neck, either by neck collar or fixator outside, or in the history, we will listen that we fixed the cervical column with plate and screw, I will anticipate that I cannot manipulate the airway in order to intubate in the proper position. Burns also can lead to fibrosis everywhere and fixation of all tissues, starting from the trachea inside till outside. It will be difficult airway. So, our next part of the lecture is manipulation and management techniques of the airway. The manipulation and techniques can be divided into two major categories: basic airway management technique and advanced airway management technique. Basic techniques are simple: head tilt, chin lift. In this picture, you will see a patient who is lying flat, and because he is lying flat, his tongue is obstructing the back of the airway, and so the airway passage is obstructed. But if I will do two techniques, head tilt by one hand and chin lift of the other hand, I am taking the tongue away from the back of the airway, so I am keeping the patency of the airway. So it is a combined process, head tilt, chin lift. Another technique is called jaw thrust, in which I am using only one part, that is the chin lift, but I am using it as thrust. It means I will put one finger over the maxilla. I will put other fingers behind the mandible. So when I am approximating the upper and the lower fingers, I will make the mandible move upward, and so the airway to be not obstructed from the back. As you see, I didn't do head tilt. Why? Because I don't want to move the neck. If I am anticipating a fractured neck or injury to the neck, I cannot perform head tilt. Head tilt can cause fracture of the neck. So by jaw thrust only, I can fix the neck and I can open the airway without causing any risk of neck to be fractured. But in case you cannot perform the maneuver of jaw thrust because it needs more experience, and the only technique you can use is head tilt, chin lift. You can use head tilt, chin lift as life-saving to the obstruction, even though it is carrying risk, but the risk of the obstruction means death. If he will continue obstructed, he will die. But if you open the airway, maybe he will be fractured, maybe not. So we are giving the upper hand to save the life of the patient and prevent obstruction. What about advanced airway management? As it appears from the name, I have used only my fingers and hands and choose the name basic airway management. In the advanced airway management, I will use instruments other than my fingers and hands. That's why it is advanced. We have several advanced airways in our hospital. First of them is oropharyngeal airway. Oropharyngeal airway is a hard plastic tube that can keep the tongue forward. It can be used only in obtunded patient, in fully unconscious patient, because it is a foreign body that will reach the throat and can cause gag reflex if the patient is awake. So, hard plastic tube that keeps the tongue forward. I should choose the proper airway size before I put inside the mouth of the patient. And I will tell you why now. How to choose the proper size? I have two landmarks. The mouth angle and the mandible angle. If I am externally putting my oropharyngeal tube and it is catching the mouth opening and the angle of the mandible, this is the proper size. If it is less, it is wrong. If it is longer, it is wrong. Why? As you see, I have here a mouth with a tongue that is obstructing the airway from the back. How will I put the oropharyngeal tube? I am anticipating to reach this position, that the curvature of the oropharyngeal airway is taking the mouth inside and getting this tongue inside it, and the curvature of it contains all of the tongue, so the tube passage can let the air come in and reach the lung. I am putting it upside down first. The curvature is facing up, and after passing half of it, I am rotating to let the curvature face down and then pushing till I reach this position. Type. I didn't answer the question now. If I will use smaller or bigger airway, what is wrong? Look at this. If I am using too short airway, what will happen? The airway will finish before reaching the uvula area, and so it will cause protrusion more and more of the tongue in obstructing the airway. And so my airway will cause obstruction by itself because it made this herniation of the tongue that occluded the airway. And if I am giving too long size, my airway itself can pass back and down and push this epiglottis and make it obstruct the trachea. So bigger than supposed to be is wrong, and smaller than supposed to be is also wrong. My second airway instrument is called nasopharyngeal airway. From its name, it will go through the nose and then will reach to the pharynx. It is soft plastic tube that is fitting the passage from the nostril to the pharynx. It can be well tolerated by semi-conscious patient. The first one we said, it must be obtunded patient. It cannot be for semi-conscious patients, but this one can be for semi-conscious. The correct side estimated depends upon two parameters. The first parameter is the diameter of the airway, and second is the length of the airway. Only length of the oropharyngeal airway I needed to check, but in nasopharyngeal airway I will check two things: the caliber of the nostril in relation to the caliber of the airway, and this can be anticipated by checking the size of the small finger of the patient. I can use size like the small finger and I can insert in the nostril. But how long should I push my airway without being afraid? I have a distance that is from the nostril of the nose till the earlobe. This distance is what I am checking. So I am checking distance and checking diameter. if I am pushing the proper size and proper distance, it will start from the nose and it will end behind the tongue. And so the passage can be patent and I can ventilate the patient and patient can take breathing normally if he wants to breathe. But it was not clear because of the obstruction. The first two, every one of us should be familiar with without a lot of experience. Our next airways, you should be trained upon. Training should be inside OR under supervision of anesthesiologist till you are familiar very well and you can manipulate anywhere. The first one is called LMA, laryngeal mask airway. Laryngeal mask airway, as you see, is different sizes. It has balloon, it has tube and opening in the middle between the area of the balloon. When we are inserting, we are inserting blindly with opening of the laryngeal mask airway facing downward and then pushing against the hard palate. We put lubricant on the back of the laryngeal mask. We are not putting on the ventral side at all lubricant. I am putting on the back of the laryngeal mask. I am opening the mouth with one hand. I am pushing against the back of the hard palate, and with help of lubricant, it will be pushed in, low and low and low till I find resistance. Once I find resistance, my connector balloon will be inflated so that the position of the opening of the laryngeal mask can be just in front of the larynx. When you are ventilating the patient with ambu bag, air will go through this tube and will come to enter trachea directly. This needs some experience. Sometimes I am telling you are not putting lubricant on the ventral side. Once I am pushing against the tongue, sometimes the tongue is obstructing me. But if you will put good lubrication and you will press against the hard palate, at that time you can bypass the tongue. Also, your thumb can take the tongue in front with you so that it cannot be pushed by the laryngeal mask airway all the journey. So, with minimal training inside OR, you can insert laryngeal mask and save patient life very fast. Another issue, another instrument that needs little or minimal training and success rate of 100% is called esophageotracheal combi tube. In this combi tube, it is composed of two inlets that will be merged to one tube, two balloons, and one exit distally, and a few fenestrae in between the two tubes. This is another picture. I have two inlets, one white and one blue. The white one is having a lumen. The lumen is continually till the distal exit. It looks like ordinary intercostal tube, ordinary endotracheal tube, sorry. The blue one, it has a lumen. The lumen will be inside the part, this part of the tube, and it will open in those small fenestrations. So if I will push air in this blue, it will come out of the small fenestrae here. It will not come from the common distal outlet. And if I will put air from this inlet, it will come directly from the distal outlet. I told you we have two balloons. One oropharyngeal balloon that can accommodate up to 100 ml of air, and the small distal one is small. It can be filled with 10 ml, 8 ml. We will see. Okay, we have two ring marks here. Sizes for oropharyngeal airway is only two sizes, one for female and one for male. We don't have several sizes like endotracheal tube, only two things. Right. How we'll do it? First, we will put the head in the neutral position. We will open the mouth, press away the tongue, and push my oropharyngeal tube, this combi tube. I will push till what? I will push till the two marks are in between the two incisors, upper and lower incisors. So I am opening the mouth, pressing the tongue away, inserting the tube and inserting along the tongue till I am reaching the incisors level, after which I will inflate both balloons. If I am inflating the big adult, the big male size, I can inflate 40 to 100 ml. If I am dealing with the female size, it will be 40 to 85 ml. As a middle, inflate by 60. Okay? Type. What about the small tube, the small balloon? I can inflate 5 to 12 ml and 5 to 15 ml. Okay. As emergency, you can inflate by 10 ml. So, in emergency, you don't want to have a lot of figures in front of you. It is written here 85 ml for big balloon, 10 ml for small balloon. And I am inflating by this order, the big first and then the small. How many possibilities is it there when I am pushing a tube blindly to the pharynx? Where it can go? It can go either to esophagus or trachea. Mostly, it will go to esophagus because it is in line with my curve. Very rare it will be in the trachea. Type. In the esophageal position, when I am inflating the big balloon, it will obstruct the oropharynx and nasopharynx, preventing any air from coming outside from the nose or mouth. And the small balloon, because it is inside the esophagus, it will seal the esophageal orifice and prevent any air to reach esophagus, the stomach if I will inflate in the blue balloon, in the blue inlet. The blue inlet, I told you before, it is opening in the fenestrine, and in case I am obstructing the esophagus and obstructing the oropharyngeal passage, any air that will come from fenestrine will reach trachea and lung accordingly after that. So in 90% maybe, I will insert blindly, I will inflate the two balloons, then if I will ventilate through the longer blue tube, air will come from the fenestrine and will ventilate the patient. But in the small percent in which I already entered the trachea, I am sealing now what? I am sealing the trachea and sealing the oropharynx. If I will ventilate from the blue, what will happen? Air will come from fenestrine and will go to stomach. I will not see chest rise. So within seconds of inserting and trying the blue, I will realize there is no chest inflation. I will put in the small white inlet, and definitely chest rise will be there. By that technique, I can assure 100% success ventilation rate for lay people who only see the tube and know how to inflate, how much to inflate, and insert blindly. Within 10 to 15 seconds, I can restore ventilation of the patient. The golden standard technique to ventilate a patient who is apneic is endotracheal intubation, seeing the vocal cord by my own eyes, inserting the tube between the vocal cords, and then ventilating the patient. But I have a problem. My airway normally, because the patient is awake, can lead the air inside, then inside means backward, then downward, then forward before it reaches the trachea. When there is obstruction of the airway and the patient is sleeping and I want to intubate, I am looking by my own eyes. I cannot find a solution to make the three axes that I have mentioned, backward, downward, and to the front, by my own eyes. I have to make all the axes parallel to each other that way in order for the light to be seen by my eyes and I can see the vocal cord. That's why I need a specific positioning of the patient. Like this, putting pillow on the back of the head, extending the neck, opening by my laryngoscope in order to see the vocal cord and to make the three axes aligned together in order to see such view, to see the vocal cord. If you are dealing with mannequin, because the rigidity of the mannequin, maybe you will need someone to open the mouth for you and to press the larynx backward so that while looking to see the vocal cord. Again, this is advanced technique that needs a lot of training, and training should be inside OR under care of anesthetist. How many intubation attempts successful? To say I am expert, it depends upon your policy and your hospital practice. In order to make your life easier, they have invented some other manipulation instruments like this air track, in which you will look here and you will see the vocal cord in the vision, but it is small. After that, they invented more advanced techniques like this. You will go by endoscopy and you will see the vocal cord. You will enter inside the vocal cord and see tracheal rings, and then push your tube inside in order to be 100% sure of position of the tube. In order to be sure that you are in position, you have to confirm the placement of the endotracheal tube using capnography, either by a capnography that puts a graph, or by CO2 detector that change color by it is blue in case no CO2, it is red, it is with CO2 like this. You have to be sure you are endotracheal. Our last part of the lecture is the differences between pediatric population and special precautions you should take care while dealing with pedia patients. Take care. First, the infant lung is a unique structure. It is not considered as many adult lung. The airway, distal lung tissue, and pulmonary capillary bed will continue to grow and develop after birth. The general pattern is laid down at birth, but upper and lower airway will continue to change. The alveoli development will be completed and will be as adult anatomy by age of 8 to 10. It means what? Before 8, it is not as adult at all. There will be ossification of the ribs and sternum that shall be completed by age of 25. So the ossification of till 25 is not constant. It is changing and it is increasing. This, generally speaking. Type one by one. We will take the nose first. Pedia population is obligatory nasal breathing. There is poor tolerance to obstruction in pediatric. The tongue is relatively large. The neck extension may not relieve the obstruction. Relatively large head. Anterior flexion will cause airway obstruction in some patients. So I don't need flexion of the head to be much, minimal head extension. Epiglottis, it is relatively large, U-shaped. It is more susceptible to trauma. It will form more acute angle of the vocal cord. I cannot see well from the epiglottis. Larynx, it is higher in level. It is anterior and keffled at the level of C3, T4. In adult, it is C4 to C5. But in pediatric, it is C3 to C4. And this will make visibility of the vocal cord and intubation difficult. The first ring in the trachea is called cricoid ring. It is the narrowest portion of the airway. In adult, the narrowest portion of the airway is the vocal cord. So if I am intubating, I am putting a tube in an adult, and the tube has passed the vocal cords, I am sure it shall not be obstructed or shall not injure anything, any part of the trachea. But in case I am speaking about pediatric population, the narrowest portion is cricoid, and I cannot see the cricoid. But while pushing the tube, if I will find resistance, I should stop, because airway edema and infection can occur if I am forcing the tube through the cricoid. It acts as a cuff during the tracheal intubation. So in pediatric population, I don't need a cuffed endotracheal tube. The trachea difference between adult and pedia, it is smaller in diameter, 6 millimeter. It has a high compliance, high resistance with airway edema and infection, collapses easily with neck hyperflexion or hyperextension, and as we said, ossification is not there 100% in age of 25, so it is malleable. Pulmonary vessels, I will have high vascular resistance and very sensitive to constriction by hypoxia, acidosis, and hypercarbia. So pulmonary hypertension is there. And if I will have hypoxia, acidosis, hypercarbia, vascular resistance will be more and more, and hypertension, pulmonary hypertension will be more and more. If you will think about the chest wall, you will find high compliance due to weak ribs, high or big anteroposterior diameter, breathing is all diaphragmatic, chest wall collapses with negative pressure because as we said before, ossification of the ribs shall not be 100% till age of 25. The work of breathing, because we have weak respiratory muscles and respiration is based on diaphragm. Decreased respiratory rate is the early sign of respiratory distress. The response of hypoxemia and increase in carbon dioxide is minimal when we are speaking about regulatory centers in the brain. The tolerance for hypoxia in children is very poor. All changes that we mention now will alert us that when we are speaking about pediatric population, we are not speaking about many adults. No, we are speaking about another category of or species of airway manipulation. Even my airway assessment in children, it shall be different from the airway assessment of adults in several factors. The infant and child will become afraid from the white-coated organism, that is us, that can encroach him or her. So the best assessment is the first look from away from the patient. Is the chest moving? Do you hear adventitious sounds from away? Are there any abnormal sound like stridor or snoring? Is there increased respiratory effort? Any retraction or respiratory is there increased respiratory effort with retraction or respiratory effort with no airway breathing sounds? Simple thing in order to improve the airway patency in children by suctioning the nose and oropharynx, reposition of child, allow the child to have the position of comfort, whatever pre-sedation he was sitting and happy with, it is the best reposition for airway patency. Head tilt, chin lift, and jaw thrust, and using airway adjunct like nasopharyngeal airway or oropharyngeal airway as usual in adult is accepted. The only difference you will see in such picture is this pillow. We are not putting in adult. In children, it can help more. And same size technique to assess the length of the oropharyngeal airway and the technique of insertion and the risk of too small or too long is the same, pedia and adult. Same airway, nasopharyngeal airway technique in choosing the size, choosing the diameter and the length, it's same. The only thing we can add here that we can use the endotracheal non-cuffed tube as nasopharyngeal airway. But you have to be sure how long you will insert and stop by it. Special concerns in what can you see in the patient and say, I am in trouble. Signs of increased respiratory effort is the first thing that will appear on the patient that can say, I have respiratory affection in this patient. Nasal flaring, chest retraction, head bobbing. Head bobbing means what? The chin lift, chin will lift and neck extend during inspiration and move down, falls forward during expiration. So the patient will be inspiration, expiration, inspiration, expiration. This movement tells I have increased the respiratory effort. Patient is in distress. What else? Seesaw respiration. if you will look to the chest, you will find the chest retracts and abdomen expands during inspiration. This is the reverse of what should be there. It is supposed to be chest inflate and abdomen will retract during inspiration. Here the reverse. Very inefficient and quickly. And if seesaw respiration is there, it means the respiration is very inefficient and very quickly this patient will be fatigued. If there is grunting, the patient exhales versus partially closing the glottis. Intentionally, the patient is trying to close the glottis and to make inside the chest pressure high so that gas exchange to be there. Proper airway positioning, if you will look in the book, you will find they are changing between, or they are differentiating between a very small child, neonate, and big children. They are putting bellow behind the shoulder in neonates and putting the bellow behind the head, below the head, in bigger children. But when I was working in Asir Central Hospital, we have found that just the shoulder roll is working both in infant and small children. Both should be behind the shoulder. Adult only, we can put it like that. This is local experience. It is not in the book. Last thing you should know while you are dealing with children, how to choose the endotracheal size. If the baby is higher than 1 year, you are dividing the age over 4 and then adding 4. For example, 2 years old means 2 over 4 is 1/2, and 4 means 4.5. Right. What about 4-year-old? It is 4 over 4 equal 1. If you will add 1 to 4, it means tube size 5. 8 age, 8 years, 8 over 4 means 2. Added to 4, it is 6 size. At all times, I will prepare half smaller than expected and half more than expected, so that if specific concern with normal variation in my patient, I can be ready with a smaller size and bigger size. Type. What if I am dealing with patient less than 1 year? Term infant 3 to 3.5, 6 months 3.5 to 4, and 1 year is 4 to 4.5. By this, we spoke about airway manipulation in special concern pedia, in adult, basic, and advanced. We did assessment and we did history regarding how to catch difficult airway before it occurs. Before I shift to the next lecture, I can have small question time. Ask me. Time. If no question, I will proceed to the fourth and the last one before prayer time. This is complications that you can encounter while sedation practice and how to manipulate it, how to manage the complication, the most common complication during sedation. Our objectives in this lecture to know what are the complications that might occur during sedation. And because we said before that our medication will affect respiration and cardiovascular systems, we will anticipate that our complications that might be seen are related to such organs. As we see here, there is a progressive affection of the airway starting from non-affected to intervention not required. Intervention may be required, need support, and cardiovascular function can be unaffected, usually maintained, and may be impaired. It is a progressive while processing from minimal sedation to moderate sedation to deep sedation and general anesthesia. So anticipated complication could be respiratory or cardiovascular. Respiratory could be depression of the respiratory or obstruction of respiratory. In cardiovascular, it can be more variables. It can be hypotension, hypertension, bradycardia, tachycardia, chest pain, and cardiac arrest. A lot of changes and a lot of complications in the cardiovascular system could be there. So let's start one by one. Regarding respiratory depression, it is depression of what? It is depression in the brain centers that governs the respiration. It can lead to decrease in depth or rate of ventilation that is attributed to depression of respiratory control centers. As a fact, all sedatives and opioids have the potential to depress the central hypercapnic and the peripheral hypoxemic drives of respiration. When we are speaking about minimal and moderate sedation, respiratory depression will be minimal. But if you are speaking about deep sedation and general anesthesia, respiratory depression will be marked. Right. How to manage respiratory depression? The best practice is to avoid respiratory depression. How to avoid respiratory depression from occurrence? By proper dose estimation, giving small incremental doses, allowing interval between the incremental doses before you give the second or the third or the fourth dose, and good proper monitoring of your patient. If you will do such 4 steps successfully, you are avoiding the occurrence of respiratory depression. I couldn't avoid for a reason or another. What can I do? I will go to the algorithm of the airway, breathing, circulation, drugs, as in basic life support and advanced life support courses. I should stop any more sedative from being given. Why did you mention as a specific step? Because as you know, we are injecting our medication not directly intravenous, we are injecting through IV lines, external lines. The tube itself from the line could contain some sedative. So when I am anticipating respiratory depression, it will be due to overdose of my medication. So I should think about flushing and throwing away any more sedative medications that are available in my tubing system that I am injecting through. What is the pharmacological actions that I can take to reverse the depression. It is by using naloxone and flumazenil according to what medication I am anticipating it has the overdose. If I am dealing with, I gave narcotics, and narcotics could be the cause of respiratory depression, the antidote is naloxone. If I am giving benzodiazepine, the antidote should be flumazenil. Naloxone 0.1 to 0.4 milligram increment every 3 to 5 minutes. Maximum recommended dose. Here I found two sources for maximum recommended dose. One of them was telling 0.8 milligram and the other is 2 milligram. طيب, in order to simplify it or to ask, to check what is the rationale that I can use when to say 0.8 is enough and I should call for help now, and I can wait till 2 milligram to be given before I can call for help. I thought about it and I am telling you, when you are giving 0.8, it means 2 ampoules with no response at all at that time, call for help. If you gave the 2 ampoules and you find only partial improvement, I can say, okay, I will complete the 5 ampoules before I can say the problem is not in the reversal of narcotics. The problem is another issue that needs my attention and calling for help. Flumazenil, it is 0.2 to 1 milligram increment intravenous every 2 to 3 minutes. Again, respiratory depression means respiratory center affection. It means overdose. It needs reversal. If I am using benzodiazepine or narcotic, I have reversal agent I will use to reverse the action, and I will improve the respiratory depression. I will take care later on of resedation because my reversal agent is shorter in duration than the narcotic or the benzodiazepine. After that, the patient is safe. Airway obstruction is another category of respiratory system complication. It means what? The upper way obstruction may be attributed to anatomical structures like the mouth, the tongue, or foreign material like vomitus. In order to maintain patent airway and to remove any material, I will do what? Head tilt, chin lift, jaw thrust, suctioning the foreign material. If this procedure can help, well and good. If not, pathological causes of obstruction should be considered. What are the pathological causes? It is laryngospasm or laryngeal edema. So, airway obstruction is 2 major categories. Anatomical structures, I can manipulate by head tilt, chin lift. I can manipulate by oropharyngeal airway or nasopharyngeal airway and suctioning of the airway. If I used such techniques and no improvement, I can think about another category that is laryngospasm or laryngeal edema. Laryngospasm means what? It is a reflex closure or spasm of the glottic muscles, including false and true vocal cords. During moderate sedation, because the cough reflex is intact, it is more prone to occur. And during deep sedation, because the reflex is obtunded, it is less frequently happening. mostly because the patient is unconscious and he cannot say, I am obstructed. His body tries to take some gestures to say, I am obstructed. This gesture, we are telling it is bucking, rocking movement, by which the patient is attempting to ventilate against obstruction, and it is occurring like this. Look at me. He's trying to have inhalation and exhalation, but he cannot. So bucking, rocking movement, if you will see from away, you will think about what? Obstruction. How can we manage laryngospasm? The airway should be suctioned, followed by forceful jaw thrust to open the airway, using bag valve mask to be placed with enough force, establish tight mask seal. Gentle continuous pressure from the bag should be applied until ventilation is successful. If we have failed, hypoxia will develop. I have to take fast action. I have to take vigorous action. I should give small dose of muscle relaxant like succinylcholine 0.1 to 0.2 milligram per kilogram intravenous, and should only be used with supplement of continuous application of positive pressure using bag valve mask. If I didn't succeed to pass the obstruction and the spasm is more and more, big full succinylcholine dose 1 to 2 milligram per kilogram should be considered, and I should intubate the patient after that directly, because full body relaxation shall be there. If I will not intubate the patient, he cannot breathe at all. The last pathology in the airway complication is laryngeal edema. It may be part of major allergic anaphylactoid reaction and will generally present as stridor, high-pitched crowing sound during breathing, and the management should be also vigorous. I will give epinephrine 0.3 to 0.5, either intramuscular, subcutaneous, whatever available, and call for help. So I will stop by now because of prayer time. I will not go through the cardiovascular complication, but lastly, before we leave, I will try to summarize. The respiratory complication can be respiratory depression, respiratory obstruction. Respiratory depression means overdose. If you will reverse the dose, the problem, and give medication, or if you avoid from the beginning, well and good. If it is not overdose, it can be obstruction, anatomical tissues, or laryngospasm and laryngeal edema. Head tilted, chin lift, and basic management of the airway and nasopharyngeal airway, oropharyngeal airway can remove the obstruction. But if it is laryngospasm, I can use the ambu bag and opening the airway and forceful pressure to release the obstruction. Maybe it shall not release. I will give small dose muscle relaxant. Maybe it shall not resolve. It will be big muscle relaxant dose and intubation. If it is laryngeal edema as part of allergic anaphylactoid reaction, I will find stridor sound and difficulty of breathing. I will give epinephrine, subcutaneous or intramuscular, and call for help. Okay, I know that within few minutes in Nagran, you will find the Zohar prayer time, and after 5 to 6 minutes our local Zuhr in Asir will be there. So we will have prayer time rest now. Prayer time, I need to come by 12:30. What do you think? 12:30 is sufficient for you to pray and come back or not? Because depending upon when we will join, the end of the day will be there. I can finish 1:30 if I will start at 12:30 and 1:30 or even 1:20 to be at home. Okay, so please 12:30 sharp to be here. I will continue the rest of this lecture and the last lecture. Okay, very nice. So 12:30 please. Thank you a lot. Assalamu alaikum. As I told you that we shall start 12:30 sharp, I want to confirm first sound is okay or not. Do you hear me well? Okay. So we finish in this lecture the first part, that is the respiratory complications. And now we will go through the cardiovascular complication. Cardiovascular complication can be more modalities, more problems that can be there. During moderate sedation, it is usually minimal as it is not affecting the cardiovascular much. However, excessive doses may trigger the cardiovascular changes. Let's take it one by one. Hypotension. Let's say that numerical values that change significantly from the baseline should alert the clinician. But evaluation of tissue perfusion is the most significant component of cardiovascular assessment. Color change in the skin and mucosa and the rate of capillary refill subsequent to the squeezing of the nail bed can be used as a guide for assessing the perfusion. If you are looking to your nail bed, it will be pink. While I am pressing with the other nail over the nail bed, it will be faded. The color will be white. I will remove directly and see how fast it is coming back to the being pink. This is the issue that can say that indicator for perfusion assessment. How to manage hypotension? Very simple. First, I will increase the preload by positioning the patient, giving 250 to 500 ml physiologic IV fluid rapidly, unless it is contraindicated. I will keep the heart rate around 60 and titrated by atropine if there is bradycardia. Ephedrine can be administered intravenously, either in 5 to 10 milligram increments every 3 to 5 minutes, or can be given 25 milligram of ephedrine subcutaneous or intramuscular injection. Don't exceed 50 milligram. It is not recommended. So first, position. Second, IV fluid. Third, check the heart rate. Keep it above 60 by using atropine. Then, if not resolved, ephedrine 5 to 10 milligram increment IV every 3 to 5 minutes. You can give 25 IM or subcutaneous and don't exceed 50. The opposite of hypotension is hypertension. Hypotension can be caused by overdose type. Hypertension, sudden elevation of blood pressure is not uncommon. Hypertensive crisis is a term that tells that diastolic blood pressure is above 120. Hypertensive crisis can be classified either it is urgent or emergent. What is the difference? I can say this is urgent if the only thing there is high diastolic pressure. There is no other complaint. The patient is not experiencing any other symptom. But I will consider the issue emergent if other than this is like chest pain, headache, visual disturbance, is plus the high diastolic blood pressure. At that time, it is emergent type. If it is urgent and only the reading is there, I will cancel my procedure. I will send the patient to a medical to assess and to medicate and to follow up before he can receive sedation and work with. But I cannot do like this if it is emergent. I have to take action. I have to give medications. Symptomatic hypertensive crisis is a medical emergency that needs definite treatment. I will use either labetalol or ismolol. Labetalol, I will give 10 milligram increment every 5 minutes, but supine blood pressure should be recorded before adding each additional increment. And take care, labetalol cannot be given in asthmatic patients. Asthmatic can take the next ismolol. Ismolol also, its increments is 10 milligram. I am giving 10 milligram increment up to 0.5 milligram per kilogram. Because of its very short duration of action, additional doses every 10 minutes may be needed to maintain the effect. This also goes to labetalol. Labetalol also is not long-acting. Neither labetalol nor ismolol should be administered without continuous ECG monitoring and continual blood pressure assessment. Okay? Right. Our next complication could be what? Could be sinus tachycardia. Mostly, tachycardia during procedure, during sedation, can be attributed to pain, stress, or using vasopressors. Three things can lead to tachycardia, and most commonly, pain, stress, vasopressor. Not only like this, but also it can be reflex to hypoxemia or reflex to hypotension. So, 5 common issues. The most critical of them, from my point of view, is reflex response to hypoxia, because it is overseen. You are thinking in the first thing that comes to you that give more sedation because patient is awake, patient is in pain, patient is in stress. This is the first thing that comes to your mind. But the earliest sign of hypoxia is tachycardia and hypertension. So, my action should be quick. I have to exclude the mentioned 5 together by looking simply to the monitor. I will look to the monitor to the oxygen saturation. Accepted. Blood pressure. High. What did I give to this patient? I gave big amount of medications or small amount of medication. Am I in a part of the procedure that is painful? Did I give any medication that contains vasopressor, local with vasopressor or whatever? I am experiencing this in a glance while I am looking to the monitor, and I am bringing back in my mind, what did I give? What is the process now in the procedure? By that, I have excluded the 5 common causes of tachycardia. After that, sustained tachycardia can be controlled by ismolol, same dose that we mentioned, 10 milligram increment every 10 minutes, to decrease the sympathetic stimulation to the heart. Okay, so we spoke about hypertension, hypotension, hypertension, tachycardia. It is progressing. I am giving my medication, and the process of the complication, cardiovascular complication, is progressing. It can lead to chest pain. Ischemic heart disease is a condition where the coronary perfusion is inadequate for the myocardial oxygen requirements. And in this condition, if you will comfort your patient, will reduce the stress-induced increase in the heart rate and the blood pressure, decrease the oxygen requirement. By that way, I can control the chest pain. Parallel to this, I shall give medication. Chest pain is a dangerous symptom. I will give nitroglycerin sublingual every 5 minutes. I can give up to 3 times until the symptom improve. or until side effects such as hypotension or reflex tachycardia occurs. Systolic pressure less than 90 contraindicates further use of nitroglycerin. So when I am giving nitroglycerin, I am checking blood pressure. If less than 90, I shall not give. I will give sublingual every 5 minutes till symptoms improve, or till side effect appears, or till 3 doses are given and no improvement. If the 3 doses are not resolving the problem with over 15 to 20 minutes, I have to consider that this is infarction, not ischemia. And at that time, I will need help. First thing, I will call for help. I will give aspirin at once if I have. If pain and anxiety are persistent, I will give opioid not as a sedative, but as a treatment for MI. If I didn't realize that patient was hypertensive and tachycardia, I didn't realize that he is in stress and ischemia started to appear, and that ischemia started to be changed into myocardial infarction, and I didn't take actions in the proper time, what could be the sequelae, the normal sequelae? That this heart will die, that MI will be transformed to cardiac arrest. At that time, my management shall be withhold the procedure, CPR, and call for help. Of course, none of us are aiming for such process. We are not happy if in case this happens. And the best practice in order to prevent this from occurring is what? Monitoring, monitoring, monitoring. Realizing what is going on. Taking proper action in the proper time. By that, no deterioration shall be there, and so our patients shall be safe. By this, I finished my 4th lecture. Do you have any question before we have the guideline lecture or not? Tell me in the chat. Clear. Well and good. So I will go now to the last lecture, and after that to take all questions through, or for all day in case we have any. This lecture actually contains 2 things. Guidelines that governs the practice of sedation. And in between, how we change these guidelines into forms. So when you will see the form and it is filled properly, you will be sure that the guideline is being followed. First, what is meant by practice guidelines? Some of us are misinterpreting practice guidelines and giving it a bigger size or bigger estimation of the outcome of the guideline. Guidelines provides basic recommendation that are supported by analysis of the current literature and a synthesis of expert opinion, open forum, and clinical feasibility data. So their content depends upon our current literature, our own opinions currently. And we all know that science changes. Whatever we are considering now right, maybe tomorrow it is less right than we were expecting, and maybe it is wrong. And so, whatever we are dependent on our information science now can be changed anytime. So, our guidelines are not intended as standards or absolute requirements for care. Even they cannot guarantee any specific outcome. It is basic recommendation. What is governing us depends upon the school of medicine that we are following. We are more happy with the American side. We will take the American Society of Anesthesiologists as our reference. British has another reference. A Canadian, another reference. Australian, like this. So we were putting the standards, the implementation of standards in Asir Central Hospital. We were speaking about the policies and procedure and the forms. People were accusing us that we are making their life miserable. We are putting a lot of burdens on them. We are putting a lot of forms on their shoulder, and they cannot tolerate working like that. We thought about what type. We will show you what reference you are happy with. American, okay. We will bring you the practice guidelines for sedation and analgesia by non-anesthesiologists that was updated by them. And we will see how Americans are dealing and what they are requesting from their non-anesthesiologists during sedation of practice of sedation. First of all, the purpose of the guideline is to allow clinicians to provide their patient with benefit of sedation while minimizing the associated risks. What are the benefits that I am planning for? To tolerate unpleasant procedure and to perform a procedure requiring no movement. What are the risks that I am planning to overcome? Overdose drawbacks and inadequate sedation drawbacks. I need to be balanced, not over and not under. I need to give benefit without any risk. Well and good. Right. The first item in the guidelines was patient evaluation. They started by history. The history of sedation should be sedation-oriented aspect of medical history. Any abnormality of major organ system. Previous adverse experience with sedation or anesthesia. Drug allergies containing medications and potential drug interactions. Time and nature of the last oral intake. And history of tobacco, alcohol, substance use, or substance abuse. This is what sedation-oriented history. After taking this oriented history, I will do focused physical examination that can include vital signs, auscultation of heart, lung, and evaluation of the airway, procedure lab testing that are guided also by patient underlying medical condition and the likelihood that the result of this lab that we are performing will affect the management of sedation or analgesia. I am not requesting kinds of lab that is routine. No, there is no routine. Shall this change my plan or affect my plan or interfere with my management? Well and good request. Because once you request, you are responsible before you start sedation that you will have the result acceptable. If it is not acceptable, withhold the process till you resolve the problem. What is my aim in my previous history and physical examination and lab investigation is to reach this slide. I want to put class for this patient. I want to give him a physical status class that tells important information for me. So we have ASA classification, ASA physical status classification, that consists of 6 classes: ASA 1, ASA 2, ASA 3, ASA 4, ASA 5, ASA 6. We can add a letter E after mentioning the ASA classification in case it is emergency procedure. طيب, let's see how we will think about classification and how we will categorize it. I will choose first ASA 6 because you shall not see in your practice of sedation, because ASA 6 means a patient already declared brain dead and we are awaiting for organ transplant. So no way for you to give sedation to perform a procedure for a brain dead patient. خلاص. Still we have 5 classes. You will see, of course. ASA 1 means patient is a normal, healthy person. And when we are speaking about healthy, we shall say that smoking and drinking can be non-healthy. So normal, healthy patient means no medical problem, not smoking and not drinking. And add something more. 2 categories of non-patients can be risky, like pregnant lady. This is not a disease in order to see she is medically compromised, but his physical condition is compromised. And morbidly obese. So morbid obesity, pregnancy, drinker, and smoker shall be considered ASA 2, not ASA 1. What else can be ASA 2? Controlled medical problem. Patient who is having hypertension, but with medication it is good blood pressure. And who is having diabetes, but it is controlled. He's having mild lung problem, but his oxygen saturation is acceptable. So ASA 2 is controlled medical conditions and smoker, drinker, obese, pregnant. This is also simple. So ASA 1 and ASA 2 are expressing themselves. ASA 3, this patient is not controlled patient. Diabetic, poorly controlled. Hypertensive, poorly controlled. COPD patient, even if he is taking the medication, his condition is not controlled and shall not be controlled 100%. Patient with renal dialysis cannot be considered ASA 2 at all. It is ASA 3. It is compromising his physical status. Active hepatitis. Plus, patient with old history of some problems. MI, pacemaker, insertion, ejection fraction below 40. And when we are speaking about long history, old history, we are speaking about more than 6 months. If it is less than 6 months, it shall be recent history. Sometimes, and some people can say, no, recent is 3 months only. I can tell you, yes, of course. In some higher centers who can deal with all problems and all deteriorations, we can consider 4 and 5 months all the history. But in ordinary hospital like ours, take care. Consider 6 months as old history, less than 6 months as recent history, to raise the bar little. I will consider, you see, ASA 4 is the recent history, MI, CVA, transient ischemic attack, cardiac stenting. This is the recent history. It will be ASA 4. So if less than 6 months, I can consider as a 4. If ejection fraction is less than 25, I will consider as a 4. So as a 3 and as a 4 difference is the word recent or distant history. If it is recent, it will be as a 4. If it is uncontrolled common diseases, renal, heart, chest, diabetes, hypertension, this is as a 3. As a 5 is a moribund patient who is not expected to survive without the procedure. Within 1 hour, he will die. Ruptured abdominal or thoracic aneurysm, intracranial bleeding, ischemic bowel. The disease sequelae shall deteriorate very fast without the procedure. This is ASA 5. Why we are concentrating that much? Because according to the guidelines, non-anesthesiologists should only sedate ASA 1, 2, and 3. ASA 4 and ASA 5 should never be given sedation by non-anesthesiologists. This is the sedation protocol in the United States. In ASIR, what we did? We did a pre-sedation assessment form starting from the organs, the systems that we are concerned about. Do we have history positive in such systems? If yes, mention in the comment. Previous sedation, yes or no? Adverse events, yes or no? And in case it is yes, give details. Same like previous anesthesia, blood transfusion, if there is problems occurred, mention. Smoker, if yes, give me details. Sleep apnea, available or not, give me details. As a classification, we will make a circle on the class of sedation or physical status. What medication patient is receiving now? Allergies available or not? In case allergy available, mention the detail. So in the first half of the paper, this is a focused sedation history taken. After which we will go to the second, the examination, the vital stability, the cardiovascular auscultation and respiration, the difficult intubation expected or not expected according to the airway assessment that was done. Malambatic classification, how much? Thyromental distance, how much? Neck range of movement, the teeth, whatever, removed, moving, denture, whatever. And how and why we chose such criteria in the airway assessment? Because we mentioned that in our policy. So each hospital can put specific assessment tools in the policy, but they will follow in the form. By that way, I can anticipate difficult airway and limited intravascular access by examination. What investigation you did and the result. After that, now I have a clear picture on the patient, and I know clear picture about the process, the procedure that I'm planning to perform. I can put a patient plan. What is my first choice agent, the route of administration, what I need more, if there is alternative needed or not, and what is it? Do I need blood or blood products or not? How many hours he will be kept in the O? What monitoring I will use post intra-op or post? Should I refer the patient to any other specialty or not? Should I give pre-medication or not, and my plan in it, post-procedural analgesia, and I will discuss the plan, the benefit, the alternative, risk, complication. Post-procedural analgesia shall be discussed with the patient or his guardian. This is a proper pre-sedation assessment. Let's go back to the guideline. The guideline has mentioned factors associated with difficult airway in the history, previous problems with anesthesia or sedation, stridor, snoring, or sleep apnea, advanced rheumatoid arthritis, chromosomal abnormality, and a physical status physical examination like significant obesity, head and neck, short neck, limited neck extension, decreased mental distance, neck mass, cervical. They mention details related to the difficult airway. And the mouth, small opening, edentulous protruding incisor, loose or capped teeth, dental appliances. In the jaw, micrognathia, retrognathia, trismus, significant small occlusion. Specific part in the guideline to awaken the non-anesthesiologist that they should be aware of the problems of difficult airway. And maybe you will be in trouble in case you will have obstruction for a reason or another. Pre-procedural preparation is part of the procedure. The patient and their guardian should be informed and agree to the administration of sedation, including the benefit, risk, and limitation associated with the therapy, as well as if we have other alternatives. Maybe you will tell him a lot of complication, and you can tell, I can resolve this problem if you will help me, if you will not move, if you will tolerate being in the MRI machine without taking any sedation. At that time, you will assure him you can give an outlet for the patient not to have problem, not to have complication. In ASIR, we put the form that the patient will sign on with condition, it is low risk or intermediate risk or high risk, and why. What are the things that made our decision, and what are the complications that can affect our decision? It is mentioned, and how. On the back of the form, you will find any alternative. You will find that the patient will sign, the physician will sign, two witnesses will sign, and in case the patient is not capable of signing for himself for any reason, the guardian shall be there. In the guideline after that, they mentioned the fasting hours, and fasting hours should be discussed clearly, and to be sure that the patient understands what is meant and how he will follow. Because what terminology we have in our mind may be misinterpreted in the patient mind. Let's see. According to the guideline, the pre-procedure fasting guidelines are clear liquids 2 hours. What is meant by clear liquids? It is water, apple juice, black coffee, black tea. But if you will speak about particulate juice, fresh juice that has particles, it cannot be considered as clear liquid. In this condition, if the clear liquid category we are in doubt about, you will go to the next step. So non-clear liquid shall be 4 hours. Right. Breast milk is 4 hours. Formula milk and non-human milk are 6 hours. Nice. Right. What about tea with milk? It will be 6 hours because it is non-human milk entrance in the solution. Light meal, 6 hours. And here I will stop for a while. Light meal, from which perspective? From my perspective or from the patient perspective, we should be clear. By the way, you will find people who are considering capsa as light meal. So I have to tell him that light meal means toast and coffee. This is light meal. I cannot consider a cheesy, full of fat sandwich as light meal, because fat will make it heavy meal. So heavy meal is not mentioned in the guideline, but it left you. You can consider it at least 8 hours. Whenever you are afraid, you step down a step, not up. And in case you are dealing with pregnant lady who is having the uterus very large and pressing on the abdomen, and morbidly obese, the timing can be more and more. Yani what, even after 10 hours, food particles could be there in the stomach and can suffocate from and can vomit and aspirate from. Take care. Non-anesthesiologist will give sedation without securing the airway and putting endotracheal tube for non-fasting patient is a crime. If the patient is not following the protocol of fasting, don't give sedation at all. Because once he will aspirate, you cannot deal with the patient and he will be asphyxic and maybe hypoxemia to the brain and will be vegetative for the rest of his life. And there is no way to say, I have a procedure, like, for example, RTA, full stomach, and just took food, and RTA, I need to make MRI brain. I need to sedate him. This is disaster. You should never give sedation to such patient. You should refer to anesthesia. Anesthesia problem shall be, I should intubate the patient and secure his airway before we proceed to do anything more, because the patient will suffocate from the vomitus. So, urgent procedure needing sedation is hospital problem, not your own problem. You shouldn't give sedation. Clear. Let's go back to the guideline. Guideline mentioned the monitoring. Monitoring, we gave the first lecture through. Let's see what they added for us. Level of consciousness. Monitoring level of consciousness reduces risks of both moderate and deep sedation. Responding of patient to command during procedure performed with sedation serve as a guide for level of sedation. Patient whose only response is reflex withdrawal can be deeply sedation, not moderate sedation. Ventilation. The primary cause of morbidity associated with sedation are drug-induced respiratory depression and airway obstruction. And so, monitoring by observation and auscultation can reduce the risk of adverse outcome. When the patient is physically separated from you, exhaled CO2 detection will decrease the risk. Monitoring oxygenation by pulse oximeter is not, I will repeat again, monitoring oxygenation by pulse oximeter is not substitute for monitoring ventilatory function. When we are speaking about oxygenation, early detection of hypoxemia shall decrease the likelihood of adverse outcome such as cardiac arrest and death. All patients undergoing sedation should be monitored by pulse oximeter and appropriate alarms. Hemodynamics, because we know sedatives and analgesics may blunt appropriate autonomic compensation for hypovolemia and procedure-related stress. If sedation is inadequate, the patient may develop potentially harmful autonomic stress response. Early detection of the change in the heart rate and blood pressure will make intervention timely and will reduce the risk of other complications also. What to record is another item. Patient level of consciousness, ventilation and oxygenation, hemodynamic variabilities should be assessed and recorded at a frequency that depends upon the type and amount of medications administered, the length of procedure, and the general condition of the patient. But in the guideline, they will mention the least only. They said that recording before the beginning of the procedure, after administration of sedative agent, at regular interval during the procedure, during initial recovery, and just before discharge. So, what is meant in this slide is that this is the least, but it is not the best practice. It is not my maximum aim of assessment and recording. This is the least. And your policy will define what is the process completely. Who shall be responsible for monitoring? A designated individual other than the practitioner performing the procedure should be present to monitor the patient throughout the procedure. So I have now at least 2 people, one performing the procedure, one monitoring the patient. However, during moderate sedation, and because we know that we have lacking of staff, maybe the individual responsible for monitoring, you can request something from him or her. This request is dependent upon certain criteria that should be available, otherwise he shall not leave the monitoring part. What are the criteria that shall be fulfilled? First, the job you are requesting is minor, interruptible task, and the patient level of sedation is stable. His vital signs stable. Adequate monitoring is continuous for the patient, and the one performing the procedure shall take over the function of monitoring in your absence. So the nurse that is responsible for monitoring, if she will bring quick thing from very near place, well and good. But if it will leave the place and will go somewhere, you cannot call her back and she cannot come in the proper time, no, call for help from another person, not from her. What forms did we do? That this is the procedure form. The first half, the first page, it has sedation induction agent, kinds of monitor patient are connected to, and the modified Ramsey sedation scale, because we know people shall not memorize properly. And in the pre-induction time, what was the time? Saturation, end-tidal CO2, respiratory rate, sedation score, pain score, vital signs, blood pressure, and pulse. What medication he will receive, everything will be mentioned in this part. After that, every 15 minutes we will write time here, and so every 5 minutes will be in the small vital place. And in case you will give medication or intravenous fluid or blood or whatever in this time, it shall be mentioned in this square related to the time. So by the end of procedure, I can draw a picture, complete picture of how was the patient, what changed was there with the patient, what intervention we did during the procedure, what is the outcome of the intervention that we did. Everything can be analyzed from such paper. Regarding the training course that non-anesthesiologists should go through, the guideline mentioned that individual responsible for patient receiving sedation, analgesia, should understand pharmacology of agents as well as role of pharmacologic antagonists for opioid and benzodiazepine. Individual monitoring a patient receiving sedation should be able to recognize the associated complications, and already such content we have done in our course. Before I go to the next item, I should tell you something. As we said in the beginning, that guidelines are the basic recommendation. Basic recommendation, if you will say it in ordinary language, I can say it is the floor that you are standing on. It is not the ceiling you are looking at. So this is the minimal requirement. Type. minimal requirement in United States. Is it mandatory for me in Saudi Arabia to follow? No. Sometimes in Saudi Arabia, we can consider issues they are mentioning too loose, too bad. And we want to strengthen the issue. We want to raise the bar. It is our life. It is our place. So some changes are there in the guideline in our favor in Saudi Arabia, and we raised the bar in it. Let's go to the next training item because it will elaborate what I was mentioning now. They are mentioning that it is recommended that individual with advanced life support skills to be immediately available. And the definition of immediately available from their point of view is to attend within 5 minutes for moderate sedation. And this advanced life support personnel to be within the procedure room in case you will give deep sedation. This is where in the United States. In Saudi Arabia, we raised the bar here. We said any patient who will receive sedation, personnel giving him sedation should be certified in advanced life support according to the age group they are giving. If they are giving sedation for pediatric, pulse, and NRP should be there. If they are giving to adult, ACLS should be there. And so, if I am asking a question, person with advanced life skill for moderate sedation in Saudi Arabia should be within the room or immediately available according to the place. If in Saudi Arabia, he should be inside the room. Immediately available is mentioned only in the United States for moderate sedation. But both of us, in case we are giving deep sedation, advanced life support personnel should be inside the room. خلاص? This is a difference between Saudi Arabia, Sibahi, and United States. Pharmacologic antagonists, as well as appropriate size equipment to establish patent airway and provide positive pressure ventilation with supplemental oxygen should be present whenever sedation is administered. Suction, advanced airway equipment, resuscitation medication should be available and in good working order. Regarding supplemental oxygen, equipment to administer supplemental oxygen should be present when sedation analgesia is administered. Supplemental oxygen should be considered for moderate sedation and should be administered during deep sedation. This is a second difference between us and them. We are giving supplemental oxygen for moderate sedation as well as deep sedation. The only contraindication to give supplemental oxygen shall be COPD patient whose oxygen saturation without oxygen supply is nearly 94. I can give oxygen supplement, nasal cannula 2 liters if saturation is low and I am planning to reach 94. But if it is 94 without oxygen, I shall not give. This is the only exception of giving oxygen supplementation for patients under sedation in Saudi Arabia. Next, combining sedative and analgesics. Sedatives here, he means benzodiazepines. Yes, we know that sedative, combining sedative with opioid is very effective during moderate sedation. But also we know that the adverse outcome likelihood can be increased, including ventilatory depression and hypoxemia. So, the golden standard, the slide that I want it to be in your blood. Intravenous drugs should be given in small incremental doses, titrated to desired effect and you will leave sufficient time to elapse between doses and each other. This is the golden rule. With this, you will give proper sedation with no complication, plus good monitoring. This is the way. Good monitoring plus this slide, you are excellent. In patient receiving intravenous medication for sedation, vascular access should be maintained throughout the procedure and until the patient has no longer at risk of cardiorespiratory depression. Again. Here we increased the bar. What they mentioned is that when you are giving intravenous medication, cannula should be there and maintained till the end of the procedure and you are happy. But in our practice, we necessitate the cannula to be there even if you are planning to give oral medication. Because even with oral medication, patient can be shocked, patient can have difficult IV access at that time, and you cannot tolerate. You cannot give the proper medication for reversing the problem. So this is another issue that we raised our bar in. Specific antagonists should be available whenever opioid, analgesic, or benzodiazepine administered for sedation. Recovery care, because there is decrease in the procedural stimulation and there is delayed drug absorption following non-intravenous administration, and slow drug elimination may contribute to residual sedation and cardiovascular depression. During recovery period, we need to complete our monitoring. Continued observation and monitoring and predetermined discharge criteria will decrease the likelihood of adverse outcome for both moderate and deep sedation. What are the discharge criteria they mentioned in the guideline? That patient should be alert-oriented. In case the patient is infant or patient whose mental status was initially abnormal, should have returned to their baseline status. Vital signs should be stable and within acceptable limits. And we should use a scoring system to assist documentation of fitness of discharge. Another issue, whenever I have given this patient a reversal agent, sufficient time up to 2 hours should pass after the last reversal dose, either it is naloxone or flumazenil, to ensure that the patient shall not be resedated again. Outpatient should be discharged in presence of a responsible adult who will accompany them home and should be able to report in case any problem will occur in the post-procedure time. يبقى outpatient will be discharged only in presence of a responsible adult who will accompany them home and will be able to report any post-procedure complication. والoutpatient والescort بتاعهم should be provided with written instruction regarding what? Post-procedure diet, medications post-procedure, activities post-procedure, phone number to be called in case of emergency. All this should be given written, because maybe they are not concentrating with verbal commands, with verbal discussion. It should be written. What we did a recovery form, same like the previous one, but we added the modified Aldrich scale, and we are monitoring and writing the modified Aldrich score, by which if the patient will get score 9 or more, or score at least like the pre-admission, he can be discharged safely. And with this, another paper that is writing the order related to the diet, activity, and medication that can be given or not given post-procedure, and the phone number that he can contact in case of emergency. This phone number can be whatever number you are holding according to the policy in your hospital. Now, we went through our training course topics. Then we concluded to link all the topics with the American Society of Anesthesiologists guidelines. Then we finished. Now you have a clear picture in front of you. My question for you shall be, what comments do you need? What question in your mind now? Ask me, please. Thanks are for you, for the company that hosted us. Again, I will tell that you should receive a PDF of the Sebahi sedation practice book as PDF and exam and assessment of the course. Thank you a lot.